Bueno, bienvenidos a todos, muy buenos días. Os iba a dar la bienvenida a la Facultad de Ciencias de la Salud como decana de la Facultad de Ciencias de la Salud, pero bueno, os voy a dar la bienvenida a la Escuela Técnica Superior de Ingeniería Industrial. Estamos en una universidad muy pequeñita, donde hay una gran interconexión entre todas las facultades. Nos gusta también interaccionar unos con otros y bueno, el Congreso va a ser igual de interesante, lo celebremos donde lo celebremos. Me presento, soy la decana de la Facultad de Ciencias de la Salud, una facultad muy nueva. Lleva un año constituida, se creó hace un año en la Universidad de La Rioja la Facultad de Ciencias de la Salud y hay un interés muy importante por impulsar todo lo que engloba esa Facultad de Ciencias de la Salud, la docencia, la formación de profesionales sanitarios. En este momento solo tenemos el grado en enfermería, pero bueno, estamos trabajando para poner en marcha otros grados vinculados con el ámbito de ciencias de la salud y también hay un esfuerzo muy grande de la Universidad de La Rioja y del Gobierno de La Rioja por impulsar no solo la docencia, sino también la investigación. Y este es un claro ejemplo, el Congreso que vamos a inaugurar hoy es un claro ejemplo de ese impulso desde todos los estamentos de la Comunidad Autónoma de La Rioja por reforzar los conocimientos en el ámbito de ciencias de la salud. Me acompaña en la mesa Raúl Juárez Vela, que es el presidente de este congreso que vamos a inaugurar hoy y le voy a ceder la palabra.
Muchas gracias, Eva. Muchas gracias y bienvenidos a todos y a todas. La verdad que es un placer estar aquí como presidente de este Congreso Internacional de la Facultad de Ciencias de la Salud, bajo el lema precisamente de investigación y docencia en salud, cuidados, basados en la evidencia, retos en la atención a la cronicidad. Y antes de nada, me gustaría agradecer a la copresidenta de este Congreso, la doctora Regina Ruiz de Viñaspre, al comité científico, al comité organizador, el esfuerzo realizado en la organización del Congreso, así como al Vicerrectorado de Investigación e Internacionalización de la Universidad de La Rioja, por todo el apoyo que siempre muestra a los investigadores de la Facultad de Ciencias de la Salud y en especial al Grupo de Investigación en Cuidados. Por otra parte, sí que no me gustaría continuar sin agradecer al Gobierno de La Rioja el apoyo, a la Cátedra Extraordinaria de Salud Pública y al Aula de Humanización Janssen por todo el apoyo. Tenemos que tener en cuenta un aspecto fundamental y es que el lema que hemos elegido es cuidados basados en la evidencia y los retos en la atención a la cronicidad. Por aportar algún dato, tenemos que tener en cuenta que el 49,3% de hombres y el 59,1% de mujeres de más de 15 años tienen alguna enfermedad crónica, según el Instituto Nacional de Estadística. Y me gustaría compartir con vosotros algo importante y es el liderazgo en los cuidados. Hace aproximadamente un año escribíamos una editorial, el doctor Vicente Gea, la profesora Teresa Sufrate, el profesor Marco Dinito, la profesora Ana Roge-Strauss y yo mismo, precisamente con un lema clave, y era invertir en enfermeras y respetar los derechos para la salud mundial. Y es que no puede ser esto dicho en un sitio mejor que en este Congreso, que tiene como lema la atención a la cronicidad. Tenemos que saber que estamos, y lo sabemos, en un mundo globalizado, enrarecido, en guerra, lamentablemente, como podemos ver, y promover un nuevo modelo sanitario ágil, resolutivo, diverso y sostenible debe ser una prioridad. Y quiero defender, además, precisamente que este cambio de modelo, las enfermeras deben ser la solución y no simplemente meros espectadores. ¿Por qué? Porque los enfermeros y las enfermeras deben ser una voz que lidere y no una voz que acompañe, porque precisamente en los retos de la atención a la cronicidad, las enfermeras son la clave en los equipos multidisciplinares. Y es por ello que dentro del abordaje de la cronicidad, las enfermeras deben ejercer su competencia política como agentes de salud con plena capacidad para transformar a la sociedad y mejorar la salud planetaria. No podemos olvidar que en los campos de liderazgo, en cuidados, se dan en muchos ámbitos y que una enfermera debe prestar estas decisiones sanitarias. por ejemplo, en el urbanismo, en el transporte, en la economía, en los residuos, en el trabajo, en la vivienda. ¿Por qué? Porque en todos estos mundos, en todos estos ámbitos, las enfermeras realmente son clave y, con su cualificación, partícipes intervinientes como agentes de salud en la vida pública, dada su versatilidad y experiencia en el trabajo de la comunidad y en este liderazgo transformacional. Un liderazgo transformador que pretendemos dejar marcado aquí en este Congreso, que refleje lo que es la enfermería del futuro. Y quiero poner de manifiesto en esta inauguración el gran trabajo que realizamos las enfermeras de aquí, de la Rioja, el gran trabajo que hace la decana y la vicerrectora de Profesorado desde la Facultad de Ciencias de la Salud y, por otro lado, el gran trabajo que hacemos todos y cada uno de los enfermeros que ahora mismo están en un hospital, en un centro de salud, en una ambulancia, ayudando a nacer o cuidando en el proceso de morir. Tenemos que tener en cuenta que hay que incluir enfermeras en el liderazgo de los cuidados. Por ir concluyendo, a las enfermeras les sobran conocimientos, talento, competencia y responsabilidad. Tienen todo lo necesario para ayudar a mejorar los sistemas sanitarios, desde el liderazgo hasta la competencia enfermera. Empoderémonos como enfermeras, transformemos la realidad social y mejoremos el nivel de salud de la población. Y un ejemplo claro es este Congreso. Muchas gracias.
Bien, a mí me gustaría que reflexionáramos sobre el bien más preciado de todos nosotros. El bien más preciado, bueno, cuando se nos hacen encuestas sobre la escala de valores, la salud está en uno de los elementos, los puestos más altos, ¿no? Pero es que por encima de la salud, el bien más preciado de todos nosotros es la vida, ¿no? Es nuestra vida, la vida de las personas a las que queremos. Y cuando queremos cuidar esa vida, estamos pensando en tanto lo cuantitativo como lo cualitativo, ¿no? En alargar los años y alargar esos años con calidad de vida. ¿Y cómo podemos alargar esos años y hacerlos con calidad, ¿no? Con bienestar? Pues a través de los cuidados, ¿no? ¿Y quiénes son los profesionales que se encargan de los cuidados, ¿no? de la vida de las personas? Como decía el doctor Juárez, los enfermeros y las enfermeras acompañan a lo largo de la vida, pero no solo en los procesos de enfermedad, sino desde el nacimiento, ¿no? Y en el nacimiento no hay ninguna enfermedad, pero hay vida, y hay una vida que hay que cuidar, que hay que mimar, que hay que acompañar, ¿no? Hay que intentar proveer de la mayor salud posible para poder vivir más años y para poder vivir con mayor calidad. Por lo tanto, si uno de los bienes más preciados es la vida y la salud es uno de los elementos más importantes para mejorar esa vida, esa calidad de vida y alargar esos años de vida, tenemos que invertir tiempo, recursos, dinero, pasión por investigar precisamente sobre la salud. Y por investigar, bueno, sobre la salud llevamos muchísimos años, llevamos muchísimos siglos investigando en el ámbito de ciencias de la salud, en el ámbito de la medicina. Pero como ya decía el doctor Juárez, hay otros elementos muy importantes, hay otros profesionales muy importantes dentro del ámbito de la salud, que sois los enfermeros y las enfermeras. Y tenemos que conocer en profundidad el mundo de los cuidados, cómo acompañar a las personas a lo largo de su vida y a sus familiares, ¿no? Por lo tanto, para mejorar, ¿no? Para seguir avanzando, para seguir adquiriendo protagonismo, ese protagonismo del que hablaba el doctor Juárez desde el ámbito de la enfermería, tenemos que, como decía, invertir en investigación en el ámbito de los cuidados y en el ámbito de la enfermería. Los enfermeros y las enfermeras hacéis un papel fundamental en el ámbito asistencial y en ese ámbito asistencial, en ese día a día, en esa acción, hay mucho sobre lo que reflexionar y hay mucho sobre lo que analizar y hay mucho sobre lo que generar conocimiento y generar nuevas teorías. Como decía el doctor Juárez, tenéis los conocimientos, tenéis la experiencia Y tenéis el apoyo de los gobiernos, el apoyo de las universidades, en este caso voy a hablar en particular de la Universidad de La Rioja, todo nuestro apoyo para seguir potenciando esa investigación en el ámbito de la enfermería. Y como decíamos al principio, es un claro ejemplo. Como decana de la Facultad de Ciencias de la Salud no puedo más que sentirme orgullosa. Como digo, es una facultad muy pequeña, pero conformado con personal, con profesorado, con investigador, con mucho potencial, ¿no? Y que en un año que llevamos de vida, bueno, pues hayamos conseguido arrancar con un congreso internacional como el que estamos inaugurando hoy, pues como digo, me llena de orgullo y me llena de satisfacción. Desde luego, toda mi enhorabuena, todo mi agradecimiento al comité científico que ha organizado este congreso, no solo al personal de la Universidad de La Rioja, sino a ese personal docente e investigador internacional que habéis sumado a este comité científico y habéis hecho que esto sea posible. Bienvenidos de nuevo a la Universidad de La Rioja, bienvenidos a La Rioja. Estoy segura de que vais a aprovechar a tope estos 2 días de este Congreso Internacional desde el ámbito científico, pero no quiero que os olvidéis de disfrutar también de los placeres que os ofrece La Rioja y que os ofrece Logroño en particular. Disfrutad del Congreso, como digo, bienvenida a todos y agradecimientos a todo el comité científico que ha organizado este Congreso. Y sin más dilación, si os parece, vamos a dar por inaugurado este Congreso. Y os dejo trabajar, que eso es lo importante.
Okay, now maybe you can hear me. So, hello everyone, and thanks to our Dean for introducing and opening this international Congress. I am Dr. Angela Durante. I have been professor of this university since April, and now I'm back to my country, in Italy. I work at the Eastern Piedmont University, which, just to give you an idea, is between Milan and Turin. So I'm going to ask the speakers of this session to join me on the stage, please. So this session is going to be full of international professionals. So there is going to be a representative of the Spanish university, so there is Professor Raúl Juárez, colleagues from Polish that are going to apologize me in advance for the bad pronunciation that I will have of their names, and 2 Italian colleagues too. So the aim of this session is to talk about self-care in chronic illnesses. As we all know, chronic illnesses are the main topic of this moment of our history. The longevity means the fact that there are much more chronic illness to deal with. So as our dean said before, it's not important to have many years if then the quality of these years is not good enough to enjoy them. So to open this session, I will leave the floor to Professor Raúl Juárez, that all you know. So please, Raúl, the floor is yours.
Bueno, antes de nada, comentar simplemente que disponen de traducción simultánea fuera y que también no se olviden de registrar con el QR la asistencia. ¿Okay? Dicho todo esto, thank you so much. My name is Raúl Juárez. I'm professor of the University of La Rioja. I have not conflict of interest, and I want to thank you to my research group in nursing care and to the big family of self-care that is composed by different universities. So thank you so much for allowing me to speak about self-care. Well, we have to know that population growth and the prevalence of different chronic diseases pose a challenge to the health system. We have to know it's really a challenge, but and the development of self-care behaviors in people with chronic condition, as well as the support by the caregiver, are crucial factor for complications. So several studies and as well several studies of our research group have shown that the self-care is the key to the management of the strategies of patients with chronic condition. But we have to take into our mind that we are speaking about chronic condition. No? For example, heart failure, diabetes, there is so much disease that we can improve the self-care, like heart disease, cancer, chronic lung disease, stroke, Alzheimer's disease, diabetes, or other chronic conditions. So self-care can be developed in different and very important chronic disease. So, two examples. For example, if we have into our mind the heart failure, we have to know that 10 million of Europeans live with heart failure, and that prevalence is around the 3% of the population, and mortality, that is important, 40% mortality within 1 year since diagnosis, after diagnosis. So it is really important to perform self-care. In addition, if you like Marvel comic, we have diabetes. Okay, what happens with diabetes? Well, diabetes as well is increasing and growing up like a chronic disease. For example, if we see the difference between the United States from 1994 to 2010, you know, we have seen that it's increasing, and now it's completely in red. So obesity and diabetes as well are self-care problems, or self-care conditions that can manage with self-care behaviors. So, do we know what are self-care? Do we know what are self-care? If I give you 5 seconds for thinking, what do you think? 4, 3, 2, 1. It's very easy. Yes? No? Or we don't know? Do we know what is self-care? Come on. Yes. Okay. Well, that's perfect. If we know what is self-care, is fantastic. Self-care, okay, is an element of managed chronic condition that enable to the patient to achieve and maintain physical and psychological stability. And there is a lot of number of activities that include medication compliance, physical exercise, and symptom control. For example, self-care maintenance is monitoring symptoms and adherence to treatment. And self-care management is recognizing symptom, evaluation, implementation, one treatment, etc. Okay? For example, other question. Can we measure the self-care? Can we measure the self-care? Yes, no, or we don't know? Okay, come on. Yes. How? Well, it's very easy. We are scientists. Nurses are scientists, okay? So we can measure the self-care. Here we have Professor Durante, who is one of the best person and what research in caregivers, okay? We have this web space, selfcare.com, that we can use for measure the self-care in patients and in caregiver. And here is 2 examples, okay, for example, of measuring self-care behavior in diabetes. For example, asking to the patient, do you maintain activity lifestyles with going out, doing activities? Or, for example, here with the heart failure, do you try to avoid getting sick? 2 different questions about self-care management. And as well, we have to know that we have to validate this case into our language. Okay? Just one example, because the self-care is not good, and we are going to see the consequence. For example, in Zaragoza, okay, let's go to see how is the self-care in heart failure patient. Well, we have that mostly men with primary study, retired, and with economy just enough to live. that never or rarely wet themselves, perform physical activity, perform exercise, as salt fault. If you have heart failure, you know that you have not to eat salt, okay, in the food. But they never or rarely ask for low salt when eating out, okay? That little changes reduce the amount of salt in the diet would reduce the fluid intake, that is important as well, or take an extra diuretic, a water pellet. So, what is the solution? Well, if I am bad, if I feel ill, I am going to call to the doctor or the nurse, but I will be continuous eating with salt, okay? So, summarize, there are poor self-care in Spain. Poor self-care management weighs down the health system and, what is worse, the patient health. Readmission rate in months, okay, is really important. And as well, for finishing, caregiver. Caregiver adapt behavior to the patient, ability to perform self-care, and in some cases are the key. Well, just a question. Who cook in this image, in this photo? Who cook? Who manage medication? Who cook with salt in food? Who is keeping an eye on doctor or nurse appointment? Come on, man or woman? Well, if the woman do that, she manages the self-care of the man, of the person that is taking care. Yes or no? The woman cook, manage the medication, and if the woman doesn't know about self-care, is going to manage very bad the health of this. But if he manages self-care, if the man cook, if the man manage the medication, or if the man cook with salt, he is managed very bad the health of the woman. Okay? Well, the most important thing is behavior to change. Awareness, the need to change, desire to support the change in self-care, knowledge of how to change, ability to demonstrate the skill and behavior, and reforming to make the change. Conclusion. Promotion, motivation in self-care should be a priority for healthcare providers involved in the care and management of the patient with chronic condition. We have to say that we have really good research in this table, that we are going to speak about self-care. They are members of our group of research, and as well future studies all investigate several countries about the disease in order to determine self-care programs, starting by to validate the skills in our language and culture. Okay? So, dear professionals, dear students, dear all, shall we work together in self-care? Well, thank you so much.
Que lo iba a decir en español. Que lo he tenido que pensar un momento, que lo iba a decir en español. So thank you, Raul, for this wonderful presentation, so for introducing the topic of this session. And while we already know that education can change lives, what matters most is motivation. So especially in older people, change habits is complicated. Are you going to say who a person, so, you know, I always like to use with the students the example of Logroño. Here there is a huge tradition in terms of wine. Are you supposed to say to your grandpa that he's not going to have a glass of wine his whole life? All the life that is going to remain for the next 20, 30 years, how many he is going to live, are you going to be able to say to him that he's not going to have a glass of wine anymore? So, despite we already know the principle of education, we have to adapt that to the values and the cultural aspect of the person that we are caring for. And on this matter, especially to the dietitian one, which is the most difficult to change, I'm going to leave the floor to Dr. Czapla. And Dr. Czapla is a dietitian and a paramedic, and especially in health promotion and health education at the Department of Emergency and Medical Service at the Faculty of Health Science of Wrocław Medical University in Poland. So, Michael, please join me and for you talk about nutritional self-care patient with their failure.
Thank you very much, Angela. Good morning, ladies and gentlemen. I'm very happy that I can be today with you, and I would like to present my 8-minute presentation about nutritional self-care in patients with heart failure. Oh, thank you, Angela. We must know that lifestyle is so important in self-care. Nutritional, physical activity, stress management, social support, and environmental exposure are used to prevent, treat, reverse the progression of chronic disease by addressing the underlying cause. And maybe you don't know, but over 90% of type 2 diabetes care, over 80% of cardiovascular disease, and 50% of strokes, and 30% of cancers could be prevented with a healthy lifestyle. And in heart failure case, poor quality of diet, low physical activity, emotional stress, and some elements that cause inflammation, oxidative stress, and contribute to obesity. Together, this factor can trigger to exacerbate hypertension, diabetes, dyslipidemia, and sleep disorders, and which can lead to left ventricular remodeling and result in heart failure. We know from our previous research findings that nutritional status both include malnutrition and obesity have significant impact for hospital mortality in heart failure case. It's one of the reasons why not only diet but lifestyle changes should be prescribed in conjunction with pharmacotherapy and other forms of therapy. But today about self-care in nutrition, please look on this schematic. It's a representation of the major nutritional related research focus areas in the context of potential challenges to implementation of nutritional intervention in heart failure. And nutritional self-care in heart failure patient is not only education about sodium and fluid restriction, dietary patterns and rules, but also about management and prevention, malnutrition and obesity. We must know that nutritional self-care is important not only for people with higher risk of cardiovascular disease, but also with newly diagnosed heart failure patients to help manage disease and improve quality of life, because it's one of important things, because we know from our research that heart failure patients who report more effective self-care have a better quality of life, lower readmission rates, and reduce mortality. When we look to European Society of Cardiology guidance, they include recommendation of self-care in nutrition area, like healthy diet, but also about fluid and sodium restriction. In most healthcare systems, the dietitian will be the person responsible for education patient, but however, a heart failure nurse or physician can and should provide initial education when visit from a dietitian is not possible, and it's important to start properly. Why? Because we must remember that Angela said today this information that food is not only diet, it's our tradition. It's about getting together with family, friends, something enjoyable. And it's better to talk with our patient about changing nutritional behaviors instead taking about diet, because the idea being of the diet for life is enough to put many patients with heart failure off. And when we talk about dietary patterns, many interventional studies show that plant-based diet have a positive impact of heart failure in terms to improve erection fraction and positive cardiac muscle remodeling. And plant-based diet is big of family diet. One of this diet is Mediterranean diet, and we have the available evidence, large, strong, and consistent. Better conformity with the traditional Mediterranean diet is associated with better cardiovascular health outcomes. And we have pyramids in Mediterranean diet, and it is an easy way to teach our patient how we can eat healthy in heart failure. Also, the DASH diet is very good because it's diet when we limited salt, and long-term adherence to the DASH diet is relevant food substitution to the DASH diet were associated with a lower risk of heart failure. Also, the dietary approach can manage blood pressure, reduce fluid retention, improve insulin resistance, and overall health. And making is a subtle choice for individuals with heart failure when tolerate to their specific dietary needs and restriction. Also, vegetarian, flexitarian, vegan diet are through the improved health cardiovascular risk and including heart failure. It's important one thing that the educator is able to explain the principles of nutrition to the patient. It's not just tell them which diet model is good, because the patient may not understand this. And in conclusion, we must remember that we have little difference between equality and equity, and we cannot give everyone the same bike. The bike, as well as a diet, should be adopted to the patient so that he or she is able to move it. Thank you very much.
So thank you, Dr. Czapla, for this wonderful presentation about dietary standards. And I would like to ask a question, especially to the students who are here, and I'm sure that are going to make me proud of their answer that I'm going to give. So in terms of cardiovascular disease, which one do you think that is the most evident that patients are going to be able to look at? Because as we know, heart failure is not evident, hypertension neither. So which one do you think that the patients understand more as cardiovascular disease? Any example? Students, don't be shy. I'm not going to evaluate you anymore. You can say in the language that you want, it's fine. I'll translate it. ¿Os lo digo en español? ¿Me vais a contestar? Vale. Si tenéis que decir cuál es la enfermedad cardiovascular que los pacientes ven más, de que se enteran más, porque la insuficiencia cardíaca no la ven, hasta cuando sea aguda. La hipertensión no la ven, hasta cuando no le dé una crisis. La cardiovascular. El infarto. Y, bueno, the answer is the infarction, of course. So they are going to, you know, this sense of afraid of, that then can be a stimulus then for the change, is the one that we are now going to talk about with Dr. Łukasz Piotrowski, and I'm sorry for the bad pronounce of these things. So please represent yourself so people are going to be aware which is the right pronunciation. And he's going to talk about self-care, about myocardial infarction. And Łukasz is a nurse and assistant professor at the Nicolaus Copernicus University in Torun, which is in Poland too. So please, Łukasz, join us.
Hello, I'm Łukasz Piotrowski, and I know it's not too simple to in other language than Polish. Thank you very much to inviting me to give a presentation. I continue to the cardiovascular topic, and my topic today will be self-care after a myocardial infarction. Why this topic? Because myocardial infarction continues pose to the a major challenge to the modern cardiology. It is often the first major manifestation of cardiovascular disease, and it is also the first cause of death in this group of cardiovascular disease. But we have seen a significant decrease in in-hospital mortality after myocardial infarction. However, the high mortality rate in the later months after myocardial infarction remains an ongoing problem. So it's the best point to start talking about self-care after this group of patients. The current fourth universal definition of myocardial infarction distinguishes between several types of myocardial infarction, of which types 1 and 2 are the most common. Why? From a self-care point of view, it is significant that both types often produce similar symptoms with pain, with sweating, disease, and anxiety. And these symptoms can be a good starting point for working with the post-myocardial infarction patient. What are the areas of the self-care after myocardial infarction? Both existing guidelines for post-myocardial infarction care for STEMI and non-STEMI myocardial infarction highlighted the same aspect to pay attention in the patient care. Here we, between aspects, focus on lifestyle modification and pharmacotherapy. The current guidelines highlight the same aspect. This is a new highlights with actually ESC Congress. Why should a group of patients post-myocardial infarction be particularly interested in self-care? As mentioned, the symptoms of myocardial infarction can be the starting point for working with a post-myocardial infarction patient. Of course, each patient may report different symptoms, but the patient journey from the honest of symptoms through to diagnosis and subconscious treatment also worries. However, all these elements might have a common best point. Anxiety and fear for life, the prospect of death, pain, fear, fear for loved ones, which as a result should motivate patients to make life change. However, any patient can fall into a trap here. What kind? Patients post-myocardial infarction usually plan a lot of rapid change in their lives. A large number of quick change can end up in failure. Therefore, the patient should set realistic, achievable goals. And the role of medical staff, it's our role, is to prepare them to self-care that will allow them to achieve these goals at the right pace, by step, how children. The main goals of recommendation for the patient and at the same time the area of self-care with include lifestyle change, pharmacotherapy, and the control of risk factors. A very important aspect of self-care is to educate the patient on how the control of underlying risk factors, including the prevention of another heart attack, another myocardial infarction. These factors will be hypertension, diabetes, cholesterol, overweight. It is important to choose right model for working with a patient. This model must correspond to the patient's real problems and real needs. In terms of these key freeze factors, most depends on patient self-care. It is essential that the patient has knowledge of the optimal diet as part of self-care. It's works for nurse, for dietitian. Often this will link to the change in existing eating habits, which has a direct impact of reduction of cardiovascular deaths. Another aspect is very important from the patient will be practice to physical activity. Physical activity is compared to a multi-component tablets polypill. It is important that the patient has knowledge of what type of activity is advisable for him and what is not allowed. We must remember here that the most of the patient had a low activity levels. Hence, it's important to adapt the works outs of increase this intensivity. When we're talking about physical activity, we must remember about sexual activity. The use of sexual activity cannot be overlooked. This is often an embracing problem for the patient. A common problem is the fear of physical exertion associated with sex, both of the part of the patient and his or her partner. Among the post-myocardial infarction patients, non-adherence pharmacotherapy is a major problem, with nearly half of patients not adhering to pharmacotherapy recommendation a long-term basis. It's important to purpose of the therapy to the patient and develop a common therapeutic plan in terms, for example, antiplatelet or cholesterol-lowering treatment. In this aspect, in these respects, it can be helpful to offer a patient multi-component medicines or the technical side, medicine boxes or reminder application. Stress, depression, and anxiety are also important aspects. They are associated with poorer treatment outcomes and make it difficult for patient to make a beneficial change to the lifestyle or adhere to treatment regimens. An important part of self-care is it to regularly check blood pressure, cholesterol, or glycemic control. This allows verification that the change might bring results. In monitoring stress, health, it is important to be remind a critic's situation, learning first aid or responding in event of another myocardial infarction. The recommendation of the European Society of Cardiology are very strong on patient participation in cardiac rehabilitation program. Why? This is because such a program allows to the patient to be properly prepared for the self-care. This is a place for multidisciplinary teams, with a nurse, with physiotherapy, with a dietitian. Let us remember to include patient families in our education activity. And let us also remember that we have ready-made tools to assess patient self-care. My conclusion, what is the key optimal self-care after myocardial infarction? I will certainly be a factual response to the patient real needs. And it's my first in Spanish language. Gracias por su atención.
So thank you, Lukasz, for your presentation. And on the continuum of the illnesses, so now we have talked about those are more common that are really burdening the healthcare system all around the globe. But now there is also another side, so the one that maybe is speak less, we know less, and where the caregiver support is much more needed. So on this matter, now we are going to listen to the presentation of Dr. Anna Rosenstrauch. I hope that my pronunciation is not so bad. And she's going to talk about the self-care in rare disease. So those diseases that are not so common as the one that we have seen now. And Anna is an assistant professor at Wrocław Medical University in Poland. And please, Anna.
Thank you.
Buenos días. Hello, everybody. I'm really feel welcome in here. It's a pleasure to be with you, and thank you for inviting me. My name is Anna Rosenstrauch, and I came from Wrocław Medical University. I am specialized in pediatric area and neonatology. And today I'm going to talk about self-care management in rare diseases. So at the beginning of my presentation, I'm going to explain what is exactly rare diseases. And most of them in a pediatric area, they are congenital and they have genetics. And as a Piotr Reed from University of Pennsylvania said that except for being hit by a car when crossing the street, all human diseases is genetics. And what is exactly a rare disease? Rare disease is a disease that affects less than 1 in 2,000 citizens. And there are thousands of rare diseases, for example, Prader-Willi, Noon, and esophageal atresia. Up to date, there are 7,000 or 6,000 rare diseases, and most of them, they are genetic, and most of them, they affect the child, the pediatric area. And most of them, 45%, they are autosomal recessive, and they are compromise children and a family life. 90% of pediatric rare diseases compromise the mostly nervous system, but also cardiovascular and also muscular, respiratory, and gastric systems. The symptoms, they are appear at the birth, and they are different from even from patient to patient, and even though from disease to disease. There is no exactly one rare disease. It's the symptoms, they can be different in each patient. We have problems with diagnosis of this kind of patient because we are lack of genetic testing, and diagnosis sometimes take long times, and we need to have a rapid and accurate diagnosis. And from the birth to the adults, sometimes diagnosis takes 3 or 5 years to give exact diagnosis of a rare disease. And to date, some of disease, they are lack of cure, and they are lack of effective treatment for this kind of patients. So self-care management in this kind of area, it's most important. Most of research nowadays focus on diagnostic problems and surgery, how to repair disease when a baby is born. There is a little knowledge about how to deal with self-care management in rare diseases. We need to communicate between internationally university to give us a good sample of patients, because we always have a problem with a study sample because of a rare disease. How to measure rare disease, how to measure self-care management. We need to use standardized condition-specific questionnaire, and which works well internationally and strengthens our statistical power in sample size and generalize of study findings, and issue of relevance to the specific population to clinical concepts. So we need to work together. We need to have more international projects to develop questionnaire to deal with rare disease in self-care management. Some of the manuscripts, they appear already to give us an answer how to deal with this kind of patients. Treating rare disease is like an endless Thai walk. We need to focus on a whole family life, on a whole emotion, eatings domain, and how to deal with medication and exercise. Most of the children, they are compromised with a gastric. They need a special diet, they need a special treatment, and we need to talk also about the education of this kind of patients. They need to be educated, even though the nervous system is compromised. And to deliberate moves to look after physical, mental, and emotional health, we need to include all self-care practice like food, exercise, medicine, emotion, sleep, and medical care. We've done some study, and we compare patients with rare diseases to patients with a cancer. As you see on this diagram, they need a health system information, they need psychological needs, physical, daily living, and patient care, and also sexuality. A lifelong holistic approach, disease-specific guideline on self-care management in 3 areas. We need to focus on childhood, on a time in adolescence, and also we need to focus on a time in adulthood. These 3 times they have a special needs, and they have like a different domain in which we need to focus. Like in adolescent, most of them, they need psychological and emotional help, but in adulthood, they struggle with finding appropriate care and support. In a childhood, we focus on a physical area mostly. So how can we improve self-care for patients with rare disease? So we need to identify gaps in existing services, and to give them multidisciplinary care which could be implemented in centers for rare diseases. So thank you very much for listening to me. If you have any question, and if you would like to give me some patient with rare disease, please do not hesitate, and you can contact me on my email. Thank you very much.
So thank you very much, Anna, for letting us understand that chronic do not mean only elderly. So not only people which are over 65 nowadays have a chronic disease, so also children with rare disease are chronic. So on this matter, there are 2 questions that we have to work on. So what are we doing, and where are we going? So in which term, as nurses and healthcare professionals in general, are we going to deal with the condition of chronicity through the lifespan? So on this matter, I'm going to invite Dr. Llaria Erba, which is recently turned into pre-doctoral research fellow at the St. Camillus International University of Health Science in Rome, and she's concluding her PhD in Rome Tor Vergata University. So Ilaria is going to talk about the state of art of self-care in chronic condition, and is going to tell us where are we going. So thank you, Ilaria, the floor is yours.
Okay, so good morning, everyone, and thanks you. It's a pleasure for me to be here today. So I would like to say thanks to the organizers and thanks to Angela for introducing me. As we know, chronic conditions are increasing worldwide, especially multiple chronic condition. We define multiple chronic condition as a clinical situation in which two or more chronic illnesses affect the same person in the same times. And among chronic conditions, diabetes, COPD, chronic obstructive pulmonary disease, and heart failure are the most common in elderly population. People, compared with a person affected by a single chronic condition, patients affected by multiple chronic conditions have a worsened quality of life, increased mortality rates, number of complications, and higher number of hospitalization. And to reduce the impact of chronic condition, self-care is essential. Self-care includes all the activities to maintain the stability of chronic condition, to monitoring and manage signs and symptoms when they occur. But despite the benefits, sometimes patients are not able to perform adequate self-care because they are often elderly with cognitive and functional impairment. And for this reason, informal caregiver has a crucial role. Informal caregiver is a family member or a close friend that help patient to perform self-care activities, and the help and the support that caregiver provide to patient is called caregiver contribution. And also caregiver contribution is theorized in the same three dimensions of self-care. So caregiver contribution to self-care: maintenance, monitoring, and management. So we can say that patient and caregiver are part of a diet. There are different types of diets depending and basing on the ways in which patient and caregiver perform self-care and caregiver contribution to self-care. And these dyadic care types has been theorized by Professor Bach. And we find patient-oriented diets in which we find patients that perform self-care alone without the support of caregivers. Caregivers-oriented diets in which patients are not able to perform adequate self-care behaviors, and so caregiver helps them during the self-care activities. Collaborative-oriented diets in which we have a collaboration between patient and caregiver, and so patient and caregiver share values, activities, decision, and also responsibilities. And we have incongruent diets. Incongruent diets are those diets in which patient and caregiver disagree on the responsibilities and on who is responsible of the care of patient and of the managing of chronic conditions. In Italy, we study self-care and caregiver contribution to self-care in this study called Sodality, Self-Care of Patient and Caregiver Diets in Chronic Condition, a longitudinal studies, and this is the research group. This study aimed to describe self-care and caregiver contribution to self-care in multiple chronic conditions. We enroll patients affected by diabetes, chronic obstructive pulmonary disease, and heart failure, and at least another chronic condition with more than 65 years old, and their caregiver with more than 18 years old in a community setting or outpatient setting, and we perform different type of face-to-face interview. As we can see from these slides, we can see that in patient-caregiver diets, self-care were significantly higher respect than caregiver contribution. So in diets in which patient is able to perform on their own self-care, caregiver contribute less. In caregiver-oriented diets and in collaborative diets, caregiver perform higher caregiver contribution. So this means that patient is not able to perform self-care autonomously. And in incongruent diet, we find differences, and we find that caregiver contribute more just in self-care management, just in the managing of chronic illnesses. In the same study modality, as Professor Juarez-Vela said before, there are different types of self-care and caregiver contribution to self-care. We have generic self-care and caregiver contribution to self-care, and specific self-care and generic contribution to self-care. And we can measure these behaviors through different types of instruments. For example, we can use the generic instrument to measure how patient and caregivers perform self-care and caregiver contribution to self-care in different types of chronic condition and in different number of chronic condition. And we have the specific instrument that are used to measure self-care and caregiver contribution to self-care in specific diseases such as diabetes, heart failure, and also COPD. Results from the study said that patient is able to perform generic self-care, so we found lower specific self-care in patients affected by heart failure and diabetes. So this means that patients are not able to perform activities of self-care depending on their diseases such as heart failure and COPD. While we have patients affected by diabetes that are able to maintain the stability of their chronic condition, so the stability of diabetes, and they are also able to manage signs and symptoms when they occur. In fact, the specific behaviors in diabetes were higher. Respect to caregiver contribution, we find the same results. So in the specific caregiver contribution of heart failure and COPD, we find lower results, lower scores. So caregivers contribute less in specific activities for heart failure and for COPD, while they are able to perform good contribution in self-care maintenance and in self-care management in the context of diabetes. So, what is important from what we can bring from the studies, that it's important to consider patient and caregiver as a diet, okay? So we have to assess the type of diets and to identify how patient and caregiver perform self-care and caregiver contribution to self-care. In this way, we can understand and notice the gap, and we can improve these behaviors where they are not able to perform good activities. It's important for a care professional that knowing how patient and caregiver perform generic and disease-specific self-care and caregiver contribution to self-care. In this way, it's possible to create a tailored intervention to improve the specific behaviors to care heart failure and COPD, for example. And for future, it's important to identify predictors and determinants of a specific caregiver contribution and self-care in COPD, diabetes, and heart failure, and also to evaluate the influence of self-care and caregiver contribution on clinical outcomes such as mortality, quality of life, hospital admission, and unplanned assessed care. So that's all. Thank you very much.
So thank you, Llaria, for your contribution. And now I have a second question for the audience. So as far as we have listened up to now, where is the right place for being able to provide care to patients with chronic illnesses? Para los estudiantes que se nos dicen que me entienden, ¿dónde vamos a cuidar a la gente que tiene enfermedades crónicas? ¿Cuál es el lugar correcto? Que no os oigo. Pues, en su casa. So Florence Nightingale used to say that the right place where to take care of the person with chronic illnesses is their home. So when we are going to provide them care, they have to be able to restore at their own home. So in this country, we have the privilege of the primary healthcare settings, but it's not the same condition for all the European countries. But as far as the only door that patients with chronic illnesses are going to find open is the one of the emergency care, we cannot complain about how many people there are in the emergency care. So on this matter, we are going to talk now with Dr. Piotr Karniej, and the title of his presentation is The Patient in Primary Care and the Role of Family Nurse Practitioner in Health Insurance System. So Dr. Karniej is an assistant professor at the University of WSP Merito in Wrocław, Poland. And the floor is yours.
Thank you very much. Thank you very much for the presentation, and thank you very much to the audience that you have decided to come here to hear me. My name is Piotr Karniej. I'm not only the assistant professor of the University Merito in Wrocław, but also I'm the nurse practitioner in primary care. And therefore, I'd like to say something about the role of the primary care nurse in practice. My colleagues said a lot about the chronic diseases, about the heart failure, and all problems that our patients are contacting to us. But the problem is that we as a nurse, as a medical practitioners, as medical professionals, have to understand our patient, and we have to understand how can we help them. And this is the main problem which is very important to us. Sometimes the people are saying that the primary care nursing is very easy, but saying the truth, it's not the truth, because we have all those patients who are under the control, under the care of the hospital, of the ambulatory special care. Of course, our patients are in the several groups. Of course, we have the healthy patients, and they are very good patients, of course, because they don't need our help in a large size. They are benefiting from preventive care, for example, vaccinations. They need to be informed about the vaccinations and the prophylaxis at all. And this is our main goal, to prevent our patients from the illnesses. We have also the patients who are healthy, but inquiring about the health of the family member. For example, the parents asking about the problems of their children. We have the children asking about the problems of their elder parents, for example, including the patients with the chronic disease. We have also the sick patients with the acute infectious disease, for example, the cold, the flu. Nowadays we have a time where the flu and those infectious problems are very, very common all over Europe. And of course we have the patient with chronic illnesses, and they are very important to us, and also the patient requiring long-term care, for example, the pressure ulcers and terminal conditions. And everything this is a primary care, and everything this is nursing in primary care, and we have to be a leader of the team, of the medical team for our patients in all those areas. Of course, very important is that my colleagues said about the management of the process of self-care, which is very important. The management needs to be prepared. So our patients have to know what the next step is to maintain our health or to improve our health. So we as a professionals have to understand what kind of management to organize to our patients. So this is very important to us because we have to understand all illnesses of our patients to prepare good management for them. Of course, very important is also to understand and to connect in this process the caregivers, because not every patient is able to self-care, and therefore the caregivers are very important to us too. I'm saying very often about nutrition at home. Raul showed us who is the cooking person at home. So when we have the patient with obesity, we can't only talk to him, you should eat this, you shouldn't eat that, but we have to talk about it to our family, to all family of this patient. So it's quite important. We have also the patient who are left in the hospital without prescriptions, without informations, with the problems, for example, unable to continue treatment on his own. For example, changing dresses. For example, not able to following the suitable diet. Taking medications appropriately. Of course, those problems are very important because our patients very often doesn't understand how important it is to continue the treatment from the hospital at home. And this is our goal, this is our role to improve it and to help our patient in these problems. So the family nurse can help with this, but only when he or she understands the patient's problems. Therefore, very important is to us to understand everything this what our teachers on the Faculty of Nursing are saying to us, the education. The education of our patient is very important, and we have to understand how to educate the patient to be understood. We can't use the words who are not understood to our patient. We have to speak very clearly. We have to speak in the patient language, which is very important in our country, in Poland, when we have also the patients from Ukraine. And not every medical professional in Poland speaks in the Ukrainian. So this is for us, for our country, for this time, a very important goal, because our language difference is the next problem. So understanding the health status of the patient, the regular consultations, so to make regular appointment with a nurse, with a doctor, with a medical professional, because all the time we are talking about the group of professionals. We are not only able to work with the patient on our own. We have to work with doctors, with the physiotherapists, with the dietitians, and with other nurses. So we are very important in these groups. And of course, we have to ask questions and to answer the patient's question. So this is very important. We can't understand, it's not able to understand the patient's problem without asking the questions. So the medication management, set reminders to take the medicines as prescribed, and keep organized whole the medical process. And of course the plan of visits, the schedule, the doctor and nurse appointment and other health related appointment in advance. It's very important to understand that our patients, if they have chronic illness, they will need the help in long term to the hospital, to the doctor, to other nurse. So it's very important to organize this help. Very important in self-care is self-monitoring. Self-monitoring, which we understand not only as monitoring of the blood pressure or the glucose level, but also the monitoring of the status. Right now we have a huge problem in whole Europe with the mental problems. The mental problems are those problems we can't measure
for example, in glucometer. It's impossible. But we understand that our patients are suffering from the mental problem, from the mental illnesses, from the depression, which is very, very, very common. So it's very important to tell our patients that the self-monitoring of the mental health, mental status is also very, very, very important. And of course, the balanced diet and exercise, the follow of healthy diet is quite important, and we know it because of the presentation of my colleagues. Avoiding stress, which is possible, because our world right now is full of stress. So it really is very important, and we have to understand that stress is very bad for our health. We as a nurse and as medical professionals have to understand that we are part of the social support. We can build and to organize also the social support, maintain the close relationships with the family and friends. We were talking about the caregivers. That's the problem, because very often we don't have those people, because we have the people who are lonely and they don't have to, they can't ask for their help. So the system of medical help is one of these of the solution. But also support groups. Consider joining a support group for the people with similar conditions, for example, with the similar chronic illnesses, which is very important to the patients. Right now we have a lot of patients who are contacting through Instagram, through Facebook, through other social applications. So this is really very important to them. But we have to understand that not always the information in these social websites are good, are valuable. So we have to understand and to correct our patient that the problem can be very important. The self-care is a process that requires commitment and collaboration with medical professionals, and the nursing can be a valuable resource in the healthcare, helping to achieve the health aims and to improve the quality of life. I think that the quality of life is very important to every one of us, and especially to our patients whose this quality is not very good and it's not very very obvious. So thank you very much for your attention, and if you will have any questions about this, feel free to contact me through those applications also. Thank you very much.
So thank you, Piotr, also for your contribution to this session. We are just in time to close with...
Good morning, everyone. I'm Isabella Santomauro. I'm a nurse and a PhD student in the University of Western Piedmont in Novara, in North Italy. Thank you for inviting me. And now I'm talking about self-care and aging society. Population aging is a major and unprecedented phenomenon of the 21st century. Data released by Eurostat 2022 show that 1/3 of the national population is aged over 65 years old. Alongside this demographic shift, there has been a change in epidemiological and clinical states of health condition. With advanced age, the prevalence of chronic and comorbidity condition has increased more and more. Chronic illnesses, besides having mortality rate, chronic illnesses, besides having a high mortality rate, can be results in complexity of care. In this slide show how the distribution of the national population based on 2022 European data takes a rhomboidal figure with the central portion showing on the of considering the patient as an active partner and actively involving them in self-care, assisting them in managing health conditions and improving overall well-being. But why is it important to talk about the self-care? Align regal perspective guiding individual towards practice of self-care can result into a health population overall with fewer individuals requiring intensive and expensive medical treatment. Following this consideration, there is a need to adopt a new paradigm, transitioning from hospital-centric model to one based on primary health care. This innovation model emphasizes the importance of community-oriented care focused on the individual and the context in which they live in the community. For this new paradigm, I am talking about the family and community nurse. It's a new role implementing the primary health care. Its implementation in Europe has occurred non-uniformly, and each country has activated family and community nurse in relation to the educational, organizational, and cultural model of their own context. The aim of family and community nurse are to increase the individual empowerment, the community empowerment, and improving a new professional collaboration. This innovation, however, requiring specific skills and new interprofessional collaboration within the healthcare team and with citizens. Indeed, among the main barriers to implementing of this new role are resistance to change from medical staff and absence legislation to recognize this new role. In conclusion, this gap highlights the need to conduct scientific studies regarding the implementing and the mapping of this new role in all Europe. Thank you for your attention.
So we thank also Isabella for her contribution to this wonderful session. So I have to say goodbye to all of you because I have a flight that is waiting for me. It has been a pleasure to have all of you and to have the possibility again to see my students. So, and I hope to see you all again as great professionals. So once again, thank you all to our speakers, and please join us for a goodbye coffee. Me dice que antes del café hay espacio para preguntas si hay. Do you have any question for the speakers, the moderator? It seems no. Any comment? I have to say that in Piedmont, they are aware of the Spanish healthcare system that we are looking at as a model, because I'm totally aware that you implemented the model in 1986, because I've been working here. So, and as the project leader of the project that Isabella is looking for, we are working through a European consultation in terms of understanding how the model has been implemented, because we are aware of the fact that we are running at different speeds. So there are countries like Spain that is made this excellent moment in a period when nobody was looking for that, which despite the issues that is experimenting is still one of the models that we look at. I have to say that in Italy we arrived very late at this point, because just the pandemic made us aware of the fact that we need to implement a family and community care model. So I had my first experience in this model in 2011, once I was here for an Erasmus in Lleida, in Catalonia. And then once I have been the privilege to be back as a teacher, I was the teacher of family and community nurse in this university. So I'm totally aware of the model, and so for the Italian crew, I can say that they know the model by me, because when we were working on the project of the implementation of the Italian one, we keep an eye on the Spanish one. So knowing also the challenges of what 20 years of implementation, 20, even 40 years of implementation have generated now. So, but I don't know for the Polish colleague if they know the model.
Maybe Peter is the best, but before to give the title to Peter, I just want to say that one reflection between the question of Emmanuel that is good, and the reflection about self-care, because usually when we speak about self-care we usually think in the hospital, but really the primary health care is a good position for develop the self-care behaviors. Here in Spain we have the good challenge of a very good healthcare system, so we have to say that really nurse can be the leader for the self-care. In addition, we have to think in self-care like that self-care can be done in every part where a nurse can lead that. For example, I know that Professor Jesus Martinez Tofe is leader on the investigation about diabetes, and as well in other part for him an emergency, other professor can do that. The idea that I want to highlight is that self-care can be done in any part where a nurse can lead the self-care. So maybe Peter is the best option to speak about the primary and the self-care. You have the microphone here. Now it's your.
Well, it's not necessary. Well, I think it is a very good question, it's a very important issue, because really we are asking very often to each other if the self-care in the primary health system, in the primary care is possible to do. And of course it is, because our system are a little different from the European perspective, but we have to understand that we have also on the level of nursing, very different level of competences in different countries. For example, the competences of nurses in Spain, in Poland, in Czechia, in I don't know, France, are a little different. And from this perspective, we have to understand that the organizing of the nursing care and the self-care, including this, have to be different. So in Poland, for example, we have very independent nursing right now, and therefore we can't work with our patient without a doctor. We are able to prescribe the medications, we are able to prepare patients for the several medical procedures. We are able to vaccinate on our own without the doctors. So our independence is really, really very huge. And therefore, in these conditions, the nurse is very often the only medical professional who is available to the patient and who is contacting to the patient, because the doctor is not necessary. Of course, in this state, we have to understand our limitations, because we are not able and we can't to replace the doctor. And it's very, very important to us for our professional responsibility and for the doctors, because we have to understand that we are working in the team. All the time we are working in the team. So we are very independent, but we can't work only on our own. So if you are asking about the system we have different systems, but we have to work in this system which is available to us. For example, our colleagues from the Ukraine, for example, our nurses who are working right now in Poland also are saying that their system is totally different from ours, and therefore they have to work in the system they have. So I think that our professional and our improving of our knowledge is leading us to be a professional nurse and a professional representative of the self-care model to our patients. Thank you.
Manuel, no sé si hemos satisfecho tu... ¿Habría algo más? Vamos, que soy una excelencia. Os tenemos de modelo. Os vamos a copiar. So on this matter, I have to say that see it in 2011 and see it when then I come back 10 years later, give me the possibility to see the good and the bad aspect of it. So, but you know, someone has to make the experience to make it turn into knowledge. So after this last consideration, if there are no other questions, I would leave the stage, and so maybe see you again next year. Bye.
exercise for diabetes, beneficial effect of educational and physical activity programs. The BNU project is founded by the and is made by a consortium coming to this.
Si te pongo demasiado, luego tú le bajas.
Sí, luego yo le puedo bajar.
Aquí van a estar, hola.
¿No? Y a ti te dejo, bueno, bueno, igual esa no...
Buenos días. Vamos a continuar con la siguiente ponencia que gira alrededor de la difusión de un proyecto de investigación europeo que es BNew, que trata sobre el efecto beneficioso de los nuevos programas educativos y de actividad física en pacientes con diabetes. Este proyecto de investigación, del que forma parte la Universidad de La Rioja a través de un grupo de investigadores de la Facultad de Ciencias de la Salud, tiene como objetivo descubrir el efecto beneficioso de nuevos programas educativos y de actividad física en pacientes con diabetes. Este acrónimo indica la necesidad de seguir un estilo de vida novedoso, incorporando la práctica del ejercicio físico en la rutina diaria. Este proyecto, que es financiado por la Comisión Europea a través del programa Erasmus Sport, cuya coordinadora del proyecto es Milena Raffi, a la que escucharemos en un vídeo ya que no ha podido asistir, e incluye entre su consorcio organizaciones con diferentes perfiles, como he dicho, incluyendo la Universidad de La Rioja, dentro del deporte, la academia y la comunicación. Estas universidades van a monitorizar y evaluar el programa de actividad física implementado por las organizaciones deportivas, estando en contacto con diferentes grupos de edad de personas con diabetes. Entonces, como digo, vamos a dar paso a un vídeo. Posteriormente escucharemos a Olatz González, que es investigadora de la Facultad de Ciencias de la Salud. Posteriormente contaremos con la participación de la doctora Basiliki Derri también a través de un vídeo, y terminaremos con la exposición de Jesús Martínez. Sin más, voy a dar comienzo a la presentación. Entonces, como digo, un pequeño vídeo de presentación de la coordinadora del proyecto y posteriormente otro vídeo en el que explicará la parte de investigación que ha llevado desde su centro.
Good morning, everybody. Thank you very much for coming to this multiplying sport event organized by the University of La Rioja. I am Milena Raffi, the coordinator of the project BNew, Exercise for Diabetes, Beneficial Effect of New Educational and Physical Activity Programs. The BNew project is founded by the European Commission and is made by a consortium of 7 partners. The University of Bologna is the coordinator. The other partners are the University of La Rioja in Spain, Democritus University of Thrace in Greece, the Association Sport of All in Suceava, Romania, the Sport for All Association of Bologna in Italy, the Sport for All Association in Ljubljana, Slovenia, and Radio Capodistria for the dissemination. As you probably know, diabetes is a chronic metabolic disease characterized by elevated levels of blood glucose. These elevated levels can lead to serious damages of heart, blood vessels, kidney, eyes, and nerves. There are several types of diabetes, but the most serious one is type 2 diabetes because it occurs in adulthood, and it is characterized by insulin resistance or very low production of insulin. In the past 3 decades, the prevalence of type 2 diabetes increased dramatically in countries of all income levels. So there is a globally agreed target to halt the rise of diabetes by 2025. The project BNew aims at uncovering the beneficial effect of new educational and physical activity programs. Indeed, the acronym BNew indicates the need of pursuing a novel lifestyle of incorporating the practice of physical activity into the daily routine. This is very important for everybody, not only for diabetic people actually. The general objective of BNew is to improve the physiological condition of people suffering from diabetes through the constant practice of physical activity. We have several specific objectives, and I think we succeeded in all four, as you will see in this event. The first one was to make diabetic subjects aware that a constant practice of physical exercise can significantly improve their health. The specific objective 2 was aimed to increase the physical activity level in the diabetic sedentary population, especially in disadvantaged people. Specific objective 3 was to evaluate the adherence of each patient to the physical activity program proposed by all partners of the project. And the specific objective 4 was aimed to implement teacher training programs regarding teaching physical activity in children or adolescents with type 1 diabetes. I hope you enjoy this event and join us in fighting diabetes. Thank you. For coming to this multiplier sport event of the project BNU. And I would also thank to Professor Raul Juarez-Vela, to Professor Ivan Santolalla, and to Dr. Olatz Cordero for inviting me to present my data in this event. I'm sorry I cannot be with you, but I hope this video recording will be of your interest. So I share the screen so you can see my presentation. You should be able to see it. I hope so. My presentation will regard the longitudinal study for motor control evaluation in diabetic people. Diabetes is a complex metabolic disorder characterized by hyperglycemia. This hyperglycemia is a physiologically abnormal condition represented by continued elevated blood glucose level. Interesting is that type 2 diabetes, which is the most common type of diabetes, it counts about 90% of the cases, can be prevented. Why? Type 1. This, which accounts for about 10% of cases, cannot be prevented. This is because type 1 diabetes is an autoimmune disorder, but type 2 diabetes is a condition in which the body does not produce enough insulin, or the body experiences the insulin resistance, and this condition usually depends on wrong lifestyle and wrong nutrition habits. So type 2 diabetes can be prevented, and this is a very good news for people with diabetes, and also for people who don't have diabetes yet, but
could be possible to experience for those people, for genetic predisposition or for wrong lifestyle. So changing lifestyle can help. Diabetes is getting a very big problem because diabetes is increasing worldwide. Diabetes hits the poorest hardest. Indeed, 4 out of 5 people with diabetes live in low and middle income countries like Southeast, South America or Middle East. Diabetes is really spiraling out of control. There is an estimation of about 537 million of people living with diabetes. And the worst thing is that most of these cases are undiagnosed. So people don't know to have diabetes, continuing to behave incorrectly in terms of lifestyle and nutrition. In my lab, we are especially interested in the diabetic neuropathy. Diabetic neuropathy is a condition which occurs few years or several years after the onset of the diabetes. It is caused by the constant hyperglycemia. So this constant high level of glucose in the blood can injure nerves in the body. And this hyperglycemia usually damages nerves in leg and feet first. So it interferes with the ability to send, with the ability of the nerve to send signals, leading to what is called diabetic neuropathy. The reason for this diabetic neuropathy is that the high level of blood sugars weakens the walls of the small blood vessels that supply the nerves with oxygen and nutrients. So everything originates by the hyperglycemia in the blood. The diabetic neuropathy symptoms range from pain and numbness in the legs and feet to problems in digestive system, urinary tract, blood vessels, and heart. So complications are very common in the diabetic pathology, and once complications are set, there's nothing we can do. So we can avoid diabetes with good lifestyle. We can delay at least the onset of the diabetes, so we can delay the progression of the pathology, but once the complications are set, there's nothing we can do. In the diabetic neuropathy, the symptoms develop very gradually, but it's clear that the symptoms will show up when it's very late. So people don't know to have a diabetic neuropathy until symptoms are very clear and very strong, because the progression of the neuropathy is very slow. Now I show you how we evaluate the motor control in general, but especially in our set of diabetic subjects. So we have this setup. You see in this drawing a person standing on 2 force platforms. Force platforms are used to evaluate the balance, the body balance. The person standing on the 2 force platforms is placed in front of the big screen, in which we retroproject optic flow stimuli. Optic flow stimuli represents the visual field So when a person stands in front of a moving screen with moving dots, like in this case, the visual system, the visual part of the nervous system interprets that the person is moving in the environment. So these kind of stimuli are useful to study the self-motion, perception and self-motion in general. This is a picture of one of our subjects placed, as you see, on the two forest platform, 1 foot on the left, 1 foot on the right. We also evaluate the eye movements, and this is the screen in which we project visual stimuli. Here is an enlargement of this picture showing electrode position, because we study simultaneously body balance and activity of leg muscles. Here you see that the electrodes are placed on the tibialis anterior, here, and on the soleus, here, of both legs, of course. We enrolled in our study 17 diabetic patients with an average age of 64 years. I show you the visual stimuli. We have 2 control stimuli. One is called baseline, in which people have simply to look at this central point while the screen is completely black. And one random stimulus, in which people have to look at the central point, but dots are moving in random directions. Those are the real optic flow stimuli, simulating a specific movement direction. So we start from full field, so we have all dots moving toward the periphery, originating from the center, so they simulate a 3-dimensional movement. We have this movement placed just in the periphery, so the central part corresponding to the foveal retina is black. And we have just a foveal stimulation in which we obscurate the periphery, so the stimulus is only in the fovea. And then we have 2 more stimuli in which we modified the visual stimulus on the left and on the right to simulate a curved trajectory. So in this case, we simulated a person who walks in the environment turning right or left. And these are examples of 2 stimuli, 2 pictures taken during the experiments. Here you see a foveal stimulus, so the person is looking at the stimulus, which is projected only in the fovea. And this is the peripheral stimulus. You see the dots are presented only in the periphery. This is the timeline of the recordings. We started at baseline at the beginning of the project. After 6 months, 12 months, 18 months, and then 4 months follow-up. We enrolled, as I said, 76 subjects. Almost everybody completed the first recording after 6 months. 54 subjects have been recorded after 12 months, 37 after 18 months, and 30 subjects after 4 months, in the 4 months follow-up. So today I will talk about this set of diabetic subjects recorded, and we made a comparison for you between active and non-active diabetic people, because of course we tried our best to include all people in our exercise programs, but not everybody applied, and not everybody is eager to change lifestyle. So we kept recording those people, this subset of people, to make an analysis of the progress of the disease with respect to the exercise intervention. So I show you first the stabilometric results. So here you see the anteroposterior dimension, so the sway in the anteroposterior dimension, so back and forth basically. So you have three plots in all slides, even in the following slides, at month 0, 6, and 12. Blue histograms represent subject active. Orange histogram represents inactive subjects. And on the x-axis of all plots, you see the stimuli, while in the y-axis of this slide, you see the anteroposterior sway expressed in millimeters. So here you see that inactive people have at baseline higher values with respect to active people, similar in the recording at the 6 months and in the subsequent year at 12 months after the active group started the exercise. So on this data we ran a repeated measures ANOVA, having the two legs, anteroposterior right and anteroposterior left values, and stimuli as within factor, and group time as between factors. So there are significant differences here expressed by group. So the anteroposterior sway is significantly different across months in the two groups, inactive and active. These are the mediolateral plots, so the sway in left and right dimension. You see again month 0, month 6, and month 12. You see clearly the differences here between inactive and active people in all plots. And here you see more evident differences between active and inactive people. This is because when people, I'm not referring just to diabetic people, but I'm referring in general. When people start losing balance, the first reaction of this effect of losing balance is to enlarge the base of support. So not to stay standing with the 2 feet close to each other, but far from each other. So that's why the recording is much more, the effect of the instability is much more evident in the mediolateral dimension with respect to the anteroposterior dimension. Indeed, we have a very significant difference for group, and we also have a difference in laterality, so left and right foot, between time. Here are the results of the muscles. The first muscle is the tibialis anterior, again at month 0, 6, and 12. And on the muscles, we see different situations. So at the beginning, you see very evident difference between active and inactive people, because inactive people have low activity of the leg muscles. So that's why here active people have a stronger activity of the muscle, because they use muscle for daily life, but especially for the exercise profile. Month 6, again, some difference. In month 12, some subjects of inactive population resulted with a higher activity. And this could be because the difficulty in maintaining balance is getting very, very high, so the muscle contraction needs to become stronger. Here we found these significant effects for stimuli, so the stimuli activated differently the muscle, and the laterality, so left and right legs behave differently. These are the results of the soleus. You see, soleus have a higher activity in the active population, and with respect to inactive population, but this higher activity is not so different from inactive people, so it's not significant. The only significant effect we found in the soleus is the stimulation, so the stimuli activated differently this muscle. The last result I show you is results of one field test. So what we did was to study the aerobic capacity, having the person walking for 30 meters and going back. So the path was to start from a specific point and to reach the second point, which was 30 meters away, and then go back. And we counted the turns in 6 minutes. That's why this test is called 6 minutes walking. This test is a submaximal exercise test used to assess aerobic capacity and endurance. And we evaluated the distance covered over a time of 6 minutes to compare changes in the performance capacity between inactive and active people. So these are the results. You see active people are dark blue, inactive people are light blue. In the x-axis you see the 3 periods, so months 0 or baseline, 6 months and 12 months. And y-axis you see the distance expressed in meters walked by people. So we have here a significant effect of activity, of physical activity, because inactive people walked about 100 meters less than, with respect to active people in all 3 recordings. So I can tell you that inactive people show larger mediolateral and anteroposterior sway with respect to active group, and that diabetic inactive people had a lower aerobic capacity, highlighting reduced cardiovascular function. So the reduced peripheral sensory and motor function, likely resulting from the diabetic peripheral neuropathy, causes muscle weakness and less neuromuscular control of the distal extremities, elements that directly contribute to a reduced motor control. And this is very serious, because one important aspect is that we need to avoid the risk of falling. But if we have reduced motor control, we are at a higher risk of falling. So this is something to keep into account, and I stress again the comment that diabetic type 2 can be avoided by performing physical activity in the daily routine and having a good lifestyle. I show you the lab members, myself, Alessandra Laffi, Andrea Meoni, Giorgia Buzzi, Aurelio Toffè, Valentina Bignami, and Alessandro Piras. And I thank you very much, everybody, all of you, for being present at this multiplier event and for your effort to strike out diabetes with us. Thank you very much.
A continuación, Olatz nos contará los resultados de los experimentos realizados en la Universidad de La Rioja dentro del proyecto BINIU.
Bueno, buenos días a todos, gracias por venir a este Multiplayer Sport Event, ¿vale? Que se realiza dentro del proyecto BINIU, ¿vale? Y dentro, a su vez, del primer Congreso Internacional en Investigación y Docencia. Vale, yo soy Olatz González, soy el técnico de investigación, ¿vale? Que ha estado trabajando en este proyecto, ¿vale? En la recogida de datos y en el trabajo deportivo con los voluntarios. Vale. En cuanto al grupo con el que hemos estado trabajando, lo encabeza el doctor Raúl Juárez. No os he puesto fotos porque ya les conocéis, yo creo que a todos o a casi todos. El doctor Iván Santolaya, María Elena Garrote, Teresa Sufrate, Ángela Durante y yo. Vale, entonces este es el grupo y entre todos pues hemos intentado sacar adelante y trabajar lo mejor que hemos podido dentro del proyecto. Vale, este proyecto empezó primero con la búsqueda de voluntarios, ¿vale? No podíamos medir las posibilidades que tiene el deporte en personas con diabetes si no teníamos primero a esas personas con diabetes para poder trabajar con ellos. Entonces, para esta búsqueda de voluntarios, pues preparamos distintos folletos y pasamos por bastantes sitios, ¿vale? Para informar de la apertura de este proyecto y de si alguien estaba interesado en participar, ¿vale? Estábamos buscando gente con diabetes, sobre todo personas con diabetes tipo 2, ¿vale? Entonces, para ello pasamos por las asociaciones de diabetes, ¿vale? En este caso la de La Rioja, que está en Logroño. Nos ayudaron mandando la información, ¿vale? A todas las personas con diabetes que tenían recogidas dentro de la asociación. Y luego estuvimos enviando el folleto, pasamos a informar a los gimnasios, ¿vale? Para que informasen de si tenían también gente con diabetes tipo 2. Pasamos por los ambulatorios, ¿vale? Y por la universidad también, pusimos anuncios, ¿vale? Y sobre todo también pasamos por el hospital, ¿vale? San Pedro. Y quiero destacar el trabajo que en este caso tuvieron varias enfermeras y toda la parte de endocrinología del hospital, ¿vale? De San Pedro, porque nos ayudaron mucho en esta búsqueda de voluntarios, ¿vale? Ellos fueron los que informaron sobre todo a las personas con las que ellos trabajaban, que tenían diabetes de tipo 2, para que tanto nosotros pudiésemos aprovechar a ellos, ¿vale? Nos pudiésemos aprovechar de ellos como voluntarios, pero para que ellos también pudiesen aprovechar este proyecto, ¿vale? Como una manera de mejorar un poquito su estilo de vida, ¿vale? Normalmente, como ya sabéis, esas personas con diabetes tipo 2 suelen ser personas con una vida muy sedentaria y que normalmente no cuidan demasiado la alimentación. Los voluntarios que hemos tenido sí que cuidan bastante la alimentación, ¿vale? No suele ser ese su problema, aunque se pasan bastante, pero bueno. Pero en el tema deportivo es donde más les cuesta, ¿vale? Entonces es donde nosotros desde el proyecto hemos hecho mayor hincapié, ¿vale? No solo porque el proyecto iba de deporte, sino porque también hemos visto que esas deficiencias iban más encaminadas en ese ámbito, ¿vale? En el ámbito deportivo. Vale, entonces, antes de comenzar a trabajar con ellos lo que es el ejercicio, el deporte, ¿vale? Hemos pasado unos cuestionarios que son los que además nos ayudan a medir, ¿vale? La evolución que han ido teniendo estas personas a lo largo del tiempo, ¿vale? Lo mismo que los cuestionarios que ha utilizado Milena en el vídeo anterior, ¿vale? Hemos hecho un cuestionario inicial, ¿vale? Antes de empezar a trabajar, a los 6 meses, a los 12 meses, a los 18 meses Y después, una vez que ha terminado en principio el proyecto a los 18 meses, 4 meses después, ¿vale? En esos 4 meses no hemos ofrecido nosotros el deporte, ¿vale? Sino que hay algunos de ellos que han seguido practicando deporte por su cuenta y otros que no. Pero bueno, eso ya está en manos de cada uno. Estos cuestionarios, ¿vale? Los podemos dividir en 3 partes, ¿vale? Una parte más personal, ¿vale? Luego una parte más física, pero de cómo están ellos, ¿vale? Es decir, si tienen alguna enfermedad, ¿vale? Si esa enfermedad les afecta y cómo les afecta. Y luego otra parte física, que es un test deportivo, ¿vale? Con pruebas deportivas para medir un poquito en qué nivel están, ¿vale? En cada una de esas repeticiones, ¿vale? En cada uno de esos meses. En cuanto al tema de los cuestionarios a nivel personal, pues hemos usado estos que os pongo en pantalla, ¿vale? Para mirar un poquito la calidad de vida que llevan, ¿vale? Si hay cambios en la calidad de vida, es decir, en el modo en que ellos perciben su vida, ¿vale? Cuando van haciendo deporte o cuando lo dejan, ¿vale? Sí suele haber cambios, ¿vale? No os he traído resultados palpables todavía, pero sí hay cambios, ¿vale? Normalmente cuando empiezan a hacer deporte, sobre todo si es de una forma habitual, ¿vale? El que va 2 días y lo deja, pues no hay ninguna diferencia. Pero el que se lo propone como rutina, ¿vale? Sí que nota mejorías a nivel psíquico también, ¿vale? Se siente más feliz, se nota con más energía, ¿vale? Y todo eso le ayuda a afrontar la vida de una forma mucho más positiva, ¿vale? Luego también, bueno, la actividad que ellos llevan a cabo diariamente, ¿vale? Es decir, se les pregunta si creen que tienen una vida activa o no y qué es realmente lo que hacen cada día, ¿vale? Hay algunos que te dicen que sí que creen que llevan una vida activa y a lo mejor se levantan del sofá 1 hora al día, ¿vale? Eso no es tener una vida activa. Pero hay otros, en cambio, que todo lo contrario, que igual dicen, bueno, no tengo una vida muy activa, pero intento moverme y tal, bueno, y luego pues hacen 4 horas de deporte, ¿vale? No vamos a poner súper intenso, pero aunque sea medio a la semana. Bueno, pues esta gente por lo menos sí que se mueve y se les nota, luego a unos y a otros. Vale, también les pasamos un cuestionario sobre problemas que puedan tener a la hora de caminar, por ejemplo, lo que les cuesta, lo que no, si les cuesta andar en llano, si les cuesta subir cuestas o bajarlas, subir escaleras o bajarlas, ¿vale? Luego un poco el miedo que tienen a las caídas, ¿vale? Que esto para la mayoría de la gente es un cuestionario pues bastante simple, ¿vale? Porque no les da miedo caerse en la mayoría de los contextos, ¿vale? Pero sí que vemos también ciertas diferencias entre gente que se siente más activa, tiene menos miedo, y la gente que es un poco más inactiva tiene miedo a caerse en sitios más comunes que el resto de personas no tendríamos. Y más o menos estos serían un poco los cuestionarios así generales, ¿vale? Luego las medidas que les tomamos, pues el peso, la altura, ¿vale? El diámetro de la cintura, del abdomen y de la cadera. Todos estos esos a lo largo del tiempo, ¿vale? Para ir viendo cómo varían, ¿vale? Tanto la altura, el peso y sobre todo la cintura, el abdomen y la cadera, ¿vale? Eso es bastante importante. Luego, los análisis bioquímicos, pues bueno, todos los que nos han mandado dentro del proyecto coger, ¿vale? La glucosa en sangre, el nivel de hemoglobina, el colesterol, lipoproteínas, ¿vale? Para saber también un poquito cómo ellos van evolucionando, ¿vale? A lo largo de ese tiempo, ¿vale? Si han estado haciendo deporte, pues lo ideal es que estos parámetros hayan ido mejorando, ¿vale? Que sí que suele ocurrir, ¿vale? No son mejoras muy radicales, pero sí que se ve que van mejorando. Y ellos, ¿cómo lo notan, digamos, no en el día a día, pero bueno, sí en semana a semana, lo ven en los niveles de glucosa, ¿vale? Cuando se toman esos niveles de glucosa, ven que les dan unos niveles de forma más regular, ¿vale? Normalmente cuando llevan ya un periodo de ejercicio, ¿vale? Continuo, ¿vale? Luego, como os he comentado, el último que solemos hacer es un test físico, ¿vale? Para medirles un poquito qué fuerza, qué flexibilidad, qué velocidad y qué resistencia tienen, tanto al inicio del proyecto como a medida que se va desarrollando todo él. Entonces, hacemos ejercicios muy simples que todos los voluntarios pueden realizar, y si hay alguno que no lo puede realizar, se le puede variar un poquito, pero en general todos están adecuados a ellos, ¿vale? Y en ningún momento tienen que hacer ningún sobreesfuerzo, ¿vale? Entonces eso les da bastante confianza cuando les pides que hagan un test de esfuerzo físico, ¿vale? Que no se tienen que esforzar demasiado. En todos tienen que ir cómodos, ¿vale? Y entonces ellos además se van viendo de cuando hicieron la prueba la primera vez, había cosas que les costaba mucho o que les sonaba a chino, ¿vale? Y con los que hemos ido trabajando poco a poco, día a día, el trabajo deportivo, pues cuando luego repiten estos testes les parecen mucho más sencillos, tanto a la hora de levantarse del suelo, de sentarse, de inclinarse hacia los pies, de levantar pesas, de levantarse ellos mismos de una silla, ¿vale? O sea, son cosas muy sencillas que al principio les cuesta mucho y una vez que se meten en el tema deportivo se les van haciendo más sencillas, ¿vale? El tema de flexibilidad, como también podéis ver ahí, también es algo que se mide, ¿vale? Y que se suele trabajar en el aspecto deportivo, ¿vale? La flexibilidad y sobre todo muy importante la movilidad, ¿vale? La movilidad de las articulaciones y la movilidad muscular, ¿vale? Para que no se vayan quedando agarrotados. Y en gente que es muy sedentaria suelen tener una movilidad muy reducida, ¿vale? Entonces es muy importante no solo trabajar la fuerza y la resistencia, que lo hacen luego también caminando, sino trabajar esos dos aspectos. ¿Vale? Y ahí abajo veis el test que os comentaba también mi compañera Milena, ¿vale? Del de los 6 minutos caminando, ¿vale? Nosotros también lo hacemos en un circuito que están 6 minutos, contamos el número de vueltas y el número de vueltas por los metros que tiene cada vuelta, ¿vale? Que en nuestro caso suelen ser 13. Vale. Aquí un poquito cómo hemos trabajado con la recogida de datos y los hemos ido metiendo en la base de datos. ¿Vale? Pues hemos ido poniendo los cuestionarios con todos los ítems que tiene cada cuestionario y luego todas las pruebas físicas, también cada prueba física pues tendría un ítem distinto, ¿vale? Entonces hemos hecho, los hemos codificado todos con números para que todos los países que estamos participando, ¿vale? Todos tanto Italia como Grecia, como Rumanía, como Eslovenia, como España, ¿vale? Trabajemos con la misma codificación y podamos pasarnos los datos sin ningún problema. Vale. Luego, en cuanto a las actividades deportivas, ¿vale? Sí que teníamos unos protocolos de ejercicio para la gente que no quería venir a las actividades que nosotros dábamos de forma gratuita, ¿vale? Y más personalizada. Hay gente que ha preferido pues, elegir el tipo de ejercicio que iba a hacer, ¿vale? Y dentro de estos protocolos teníamos el ejercicio aeróbico, ¿vale? Que se basaba sobre todo en salir a caminar, ¿vale? Y digo a caminar y no a pasear, porque pasear no es hacer ejercicio, ¿vale? El ejercicio necesita que suban un poquito la frecuencia cardíaca, ¿vale? Y paseando no se consigue ese objetivo. Entonces hay que salir a caminar, ¿vale? Hay que ponerse, aunque yo esté paseando 3 horas al día, tengo que caminar por lo menos 1 hora, ¿vale? Es decir, que mis pulsaciones estén un poquito más animadas de lo habitual, ¿vale? Por lo menos durante esa hora. Eso es salir a caminar, ¿vale? Antes de salir tengo que hacer un calentamiento, ¿vale? Muy importante, sobre todo para la gente de este tipo que suele tener algo de sobrepeso, ¿vale? Entonces, para ellos es más importante porque las articulaciones van a sufrir, ¿vale? Cada impacto que damos caminando, las articulaciones lo notan. Cuanto más peso llevemos encima, más lo notan. Entonces, si son personas que tienen mucho peso, es muy importante que calienten primero, ¿vale? Y al final una pequeña relajación, ¿vale? Unos pequeños estiramientos para ayudar también a esa movilidad, como hemos dicho, ¿vale? Tanto antes como después. Tendríamos también el ejercicio de natación, ¿vale? Otro ejercicio aeróbico que podían elegir entre uno u otro, ¿vale? El ejercicio de nadar lo han elegido muy poquitos, ¿vale? La mayoría se han tirado al de caminar, es mucho más asequible para todos, lo tienen más a mano y todos estamos más acostumbrados a caminar que a nadar normalmente. Y el tercero que teníamos era el de fuerza muscular, ¿vale? El de fuerza muscular lo podían hacer a través de gimnasios, ¿vale? O a través de tablas de entrenamiento personalizadas, ¿vale? O si no, viniendo a nuestras clases particulares que hacíamos con grupos reducidos, ¿vale? Que eran de forma gratuitas para ellos. Entonces, sí que ha habido alguno que ya tenía algo de conocimiento que se apuntaba a gimnasios, ¿vale? Y entonces han ido con las tablas personalizadas a esos gimnasios, ¿vale? Siempre basándonos en una tabla general que trabajábamos desde el proyecto, pero personalizando un poquito para cada uno, ¿vale? No todos pueden hacer lo mismo. Y sí que hemos tenido también varios grupos, ¿vale? Tanto por la mañana como por la tarde, de voluntarios que han estado viniendo a esas clases deportivas que nosotros ofrecíamos gratuitas. Y esos son los que, bueno, pues aparte de lo que nos ha salido en los resultados, más se puede ver lo que han ido evolucionando. Vale, otra fase del proyecto, ¿vale? La segunda fase es la que está un poco más enfocada a profesores, ¿vale? En esta fase nosotros lo que hemos creado ha sido un curso online, ¿vale? Que está compuesto por 7 lecciones, ¿vale? Que hablan un poquito de educación física y actividad física para personas con diabetes, ¿vale? En este caso, sobre todo, enfocado a niños y adolescentes con diabetes, ¿vale? Cómo los profesores pueden, tratar a esos niños, ¿vale? Qué cosas les pueden permitir y cuáles no, y el deporte que pueden hacer, ¿vale? Y durante estas 7 lecciones pues tenemos a 6 ponentes diferentes, ¿vale? Que somos los componentes del proyecto, ¿vale? En estas lecciones, pues lo que tenemos, aparte de la lección en sí, lo que es la teoría, tendríamos también propuestas distintas actividades, ¿vale? Distintos materiales, como podéis ver aquí, cómics, tenemos también esquemas, ¿vale? Y luego contamos también con algunas entrevistas, ¿vale? Tanto, sobre todo, de padres y madres que tienen los niños con diabetes, ¿vale? También dentro de este curso tenemos varios cuestionarios para ir viendo cómo han evolucionado, ¿vale? Los profesores, es decir, qué sabían antes y qué han aprendido. Y ellos también lo pueden ir viendo a través de tests de autoevaluación, ¿vale? Y con esto más o menos os explica un poco lo que es el proyecto en La Rioja, ¿vale? Y todo lo que hemos hecho dentro del proyecto. Pues espero que os haya gustado y muchas gracias por la atención.
Gracias, Olaz. Como os comentaba, ahora vamos a ver un vídeo de la profesora Basiliki Derri, en la que nos contará sus investigaciones también dentro del proyecto VINU.
Good morning, everybody. Buenos días. I am Basiliki Derri, professor at the Democratic University of Thrace in the School of Physical Education and Sport Science. It's a great honor and pleasure to be here with you at this round table talking about the BNU project and specifically for PE teachers training in Greece. I would like to thank a lot our colleagues from University of La Rioja for this invitation and also for their valuable collaboration in the project, and wish, of course, great success in this Congress and in whatever they do. Here is our team, our DUTH team, our Democratic University of Thrace team, a part of me. The participants, my colleagues, are Professor Maria Michalopoulou, Professor Helen Douda, Professor Thomas Kourtesis, Associate Professor Elias Milios, Dr. Apostolos Passis and Kyriaki Manouilidou, who belong to the special educational staff in our department, and also stakeholders from education and physical education, Dr. Aspasia Papamichou, who is also a PE counselor of Evros and Kavala, and Athanasia Gaitanidou, who is also director of primary education of Kavala. Last but not least is our Chris Kazantzis, special technical laboratory staff. The big new goals for the PE teachers and children adolescents were to improve teachers' knowledge and practices and coexistent co-education and inclusion of children adolescents with type 1 diabetes in physical education and physical activity programs in general. Indirectly, we had as a goal to improve children with type 1 diabetes and non-diabetic children on health-related quality of life, health-related fitness and social skills through the PE course and the training of their PE teachers. This slide shows our participants. 2 years, the first year 2021 to 22 and the second year 2022 to 2023. During the first year, the participants, the physical education teachers, the children and their parents were from East Macedonia and Thrace, where our university belongs, and also from Central Macedonia. During the second year of the project, physical education teachers, children and their parents participated from all prefectures of Greece. The teachers were separated in 2 groups. The experimental, who followed the training program in the frame of the BNU project, and the control group who did not follow the training program. The children and their parents who were with the teachers who were trained also were enrolled in the experimental groups, while the others in the respective control groups. In each group, experimental or control, there were children with and without diabetes. The tools that we used to evaluate PE teachers' knowledge on type 1 diabetes and the teaching practices of the teachers are presented here. Also, to evaluate children in the aforementioned variables, studied variables, we used the fitness gram package to evaluate their health-related fitness. We used the Kid Screen 52 for children and parents to evaluate children's health-related quality of life. And for the younger ones, we used the Kindle questionnaire. And also we used the quality of life diabetes 3.0 diabetes module to evaluate quality of life of diabetic children only. We used for the teacher training, we used platforms for the asynchronous delivery of the lectures and the synchronous delivery of the lectures. The first year we used the e-class for the asynchronous lectures, and the second year the emails of the teachers. The first year also we used the MS Teams for delivering the synchronous lectures. The same platform was used during the second year. When we used the e-class for the asynchronous delivery, we created, as you can see in the pictures, an e-class lecture, an e-class for the BNU experimental group. The goals of the physical education teachers training program were to enable them recognize the signs and symptoms of diabetes, have basic knowledge of exercise physiology about diabetes, identify the benefits of physical education and physical activity in and out of school setting in developing children holistically, psychomotor, physical condition, health, cognitive, emotional and social skills and health-related quality of life. Also, to follow the international guidelines in physical activity programs, to set learning goals that can be achieved by both students with diabetes and by their classmates in the PE course, as well as other related programs. To design and implement physical education, physical activities based on contemporary inclusive methods and practices, and to evaluate their effectiveness. Also, to know how to evaluate the progress and the achievement of students. The teachers followed the 3-month period training with 9 lectures, 3 of which were asynchronous. These lectures were, of course, on the inclusion and co-education of people with type 1 diabetes based on the project goals. They attended the lectures, they participated in assignments, they uploaded their work, they received feedback individually and in plenary sessions. They reported problems they were facing, but also positive results, and they kept diaries in the last 3 lectures where, as you will see, they created their lesson plans based on the goals of the project and what they had learned, and implemented these classes, as we will see right now. More specifically, the lectures were the following. The first lecture was an introductory one on the BNU project, the goals, the quality of life and health, the physical activity and physical education, and also on the procedures to be followed. The second lecture was dedicated on diabetes, on identifying the symptoms, the signs, the body functions that relate to diabetes mellitus and the benefits of physical activity and physical education. Also, international guidelines and other guidelines were presented in this lecture. In the third one, the goal setting and the selection of activities or content in general was the goal. Then, in the fourth one, we focused on teaching, contemporary teaching for physical education and physical activity, and also how to create a bridge between the school physical activity and the out-of-school physical activity. The sixth lecture was based on scenarios or on lesson plans which they were ready-made, and they were provided to the teachers to make the appropriate modifications in order to be related, strongly related and aligned with the contemporary lessons and also the BNU goals. During the 7th, 8th and 9th lecture, as I told you before, the teachers were more actively involved. They were actively involved in the whole project, but in these ones they were more actively involved since they created their own activities, lesson plans, and they implemented them in the 8th and 9th lecture. We provided feedback to them both for the design and the implementation, and they also provided feedback back to us depending on how it worked in real settings. The results. Now, as I said in the beginning, the goal was to train teachers in order to reinforce them and to co-educate children with type 1 diabetes and without diabetes. However, we tested also variables to children. Now we will present the results for the PE teachers. In regards to their knowledge, as we see in the graph, the blue lines are for the experimental group of teachers, the teachers who followed the program. We see that there is a significant improvement in their knowledge and, of course, retention of their knowledge in contrast to the control group, who showed an improvement, but this was not statistically significant. Teachers also wrote their views on their practices, how if and how they use aspects of effective teaching. So we see in the graphs that the teachers in the experimental group had a steady improvement in all 6 variables here, while the control group didn't show such a steady improvement, or in some cases also lowered the views, lowered the scores, as for instance on content or on lesson implementation and other aspects. In regards to children and health-related fitness, we see that the experimental group, in this graph, the experimental group had a significant improvement in carer apps from the initial to the retention measurement. The same was for the diabetic children in this experimental group, and for the non-diabetic children in the same group, that is the experimental group. The same happened with the trunk lift. The experimental group saw the significant improvement in contrast to the control group, and this improvement was also significant for the diabetic group in the experimental group, for this subgroup. The non-diabetic experimental group showed an improvement, but it was not statistically significant, while the control group showed no improvement. In regards to sit and reach, we see that, again, we see that the experimental group shows a slight improvement, while the control group shows a slight deterioration. In regards to the diabetic experimental group, we see a significant better performance in sit and reach, which is a test for flexibility, in the retention measurement. The same is evident for the non-diabetic experimental group. Similarly, in push-ups, children in the experimental group were significantly better. They improved significantly from the initial measurement to the retention measurement, and this is evident also for the 2 subgroups of children, both for the non-diabetic and diabetic group. In regards to health-related fitness aspect, cardiovascular endurance, no significant differences were observed, but the experimental group shows a slight improvement in contrast to the control group. Here the lower score is the better. Also, in regards to health-related quality of life and based on children's responses for their relationship with friends and their relationship with their family, we see that there is an improvement in the experimental group, while in the control group there is a steady score in their views, or even a slight increase when we talk about the friends. In regards to mood, the experimental group again showed a significant difference. It was significantly better than the control group. Here the lower score is the better. And in school, also we see that the experimental group, that is children whose teachers follow the training program, are significantly better than those in the control group. The conclusions. The training program in the frame, the teacher training program in the frame of the BNU project improved significantly not only physical education teachers' knowledge on diabetes type 1 and their practices, although not significantly, but also children's health-related fitness and aspects of health-related quality of life, despite the fact that we were indirectly related to the children, I mean the goals of the project. These improvements were apparent for the whole experimental group, but also for its subgroups, such as the diabetic and non-diabetic experimental group. Also, the training program seems to have affected other variables of children in the experimental group, such as lowering their worries or their problems with diabetes or improving their emotions. But up until now, we haven't finished yet the data processing and analysis. So we need more time to be able to present all the results of all the positive results, as it seems, from this project. Further research on educating children by trained pets, physical education teachers, is required to highlight the results of pets training on children's health and quality of life through physical education in and out of the school setting. Thank you very much for your attention. I hope to see you soon, and I wish you luck with whatever you do. Thank you.
Bueno, para terminar esta ponencia dedicada al proyecto BNU, contamos con Jesús Martínez, que es investigador del Grupo en Investigación y Cuidados de la Universidad de La Rioja, que nos va a hablar sobre sus investigaciones sobre la diabetes. Antes de comenzar, solo dos recordatorios. Uno es que el resto de las actividades del Congreso se van a celebrar en la Facultad de Ciencias de la Salud, no en este edificio. Y que os recuerdo que para el control de la asistencia tenéis unos códigos QR, hay uno aquí a la entrada, pero que tendréis que utilizarlos para cada sesión. Es decir, hoy uno por la mañana, otro por la tarde en la Facultad de Ciencias y mañana tendréis que registrar otro código QR. Gracias.
Buenos días. Gracias, Iñaki, por la presentación. Gracias a la Universidad de La Rioja por organizar este congreso y por permitir que presentemos nuestro trabajo aquí. Bueno, yo esta mañana he estado aprendiendo un montón porque hemos estado escuchando a investigadores que realmente son referentes tanto nacional como internacionalmente para nosotros y no somos conscientes en algunas ocasiones, pero ese grupo de investigadores engloban cientos de publicaciones. A mí personalmente, además de aprender muchísimo, me da miedo que al ver a ese tipo de personas, los profesionales sanitarios que trabajamos en los hospitales, en los centros de salud, podamos sentirnos abrumados y digamos, a ver, yo tengo una buena idea, yo estoy trabajando aquí en mi centro de salud, pero ¿qué voy a hacer yo? ¿Voy a poder hacer una investigación a esa altura? Entonces, bueno, este es un congreso de investigación y no solo venimos a aprender de los mejores, sino que también venimos a motivar, a fomentar y a animar a la gente a las bases a que investiguemos, porque es la forma de hacer mejorar nuestra profesión y que basemos los cuidados en la evidencia, que es uno de los lemas de este congreso. Yo personalmente soy del segundo grupo. Soy Jesús Martínez Tofé, soy enfermero y trabajo de forma asistencial en el Hospital San Pedro de Logroño, en el bloque quirúrgico. Además de trabajar en el hospital, formo parte de GRUPAC, que es un grupo de investigación de la Universidad de La Rioja especializada en cuidados. Principalmente somos enfermeros haciendo ciencia y he de decir que todas las carencias que los enfermeros quizás asistenciales o los que no tenemos mucha experiencia en la investigación podamos tener, viene completada por grupos de investigación como este, que sin el que yo personalmente no podría haber hecho nada de lo que estoy haciendo. Entonces, bueno, agradecer tanto a las universidades como a estos grupos el apoyo que nos muestran, pero también hay que decir que nosotros, desde el mundo asistencial, aportamos muchas cosas que desde la universidad no se tiene, que es la experiencia día a día con nuestros pacientes. Vemos los problemas que tienen las enfermeras, vemos los problemas que tienen los pacientes y podemos aportar ese granito, generar sinergias entre los equipos. Yo estoy realizando mi tesis doctoral en el campo de la diabetes y del autocuidado. Poco más hay que aportar o poco puedo hablar respecto a este tema cuando han estado hablando toda la mañana gente que es muy experta y que lo ha explicado brutalmente, ¿no? Pero yo, bueno, voy a aclarar alguna cosita que igual me ha parecido que os podría ayudar, sobre todo para esas personas que se sienten identificadas con lo que he expuesto, ¿vale? Yo trabajo con personas con diabetes mellitus. Yo elegí esta temática, este tipo de pacientes, porque, bueno, como ya sabéis, los pacientes crónicos son personas que van a estar toda su vida con una mochila, ¿no? Que es la mochila de su enfermedad. Esa no se la van a poder quitar nunca. Hay enfermedades crónicas que a lo largo de los años se va introduciendo peso en esa mochila y tienen que aprender a vivir con ese peso. Pues cada vez, cada año, con el paso del tiempo, el peso es superior y pueden vivir peor, con menos calidad de vida. ¿Qué ocurre con la diabetes? Que es muy dependiente de los estilos de vida, con cómo nos cuidamos, qué hacemos nosotros, qué estilos de vida adoptamos. ¿Qué genera eso? El que la labor de los enfermeros, la labor de los programas sanitarios de enfermería tengan una repercusión brutal en su calidad de vida. Entonces, a mí me parece que es muy recompensante el hecho de poder trabajar con ese tipo de personas. Bueno, esta foto es de Bárbara Riegel, que solo quería poneroslo por decir que es una enfermera, y ella desarrolló la teoría de rango medio del autocuidado de las enfermedades crónicas. Esto es la base de todas las teorías con las que trabajamos nosotros y bueno, los cuestionarios con los que trabajamos. Es decir, no nos basamos en unas teorías desarrolladas por otras especialidades, medicina o cualquier otra especialidad, y las adaptamos a la enfermería, no. Son enfermeras que han desarrollado teorías y nosotros trabajamos con ellas, trabajamos con evidencia, ¿de acuerdo? Decir con respecto a los autocuidados que, acorde a lo que decía esta mañana Ángela, que nosotros vivimos, por suerte, en un país con un sistema sanitario de alta calidad. Eso es muy bueno, pero para los autocuidados yo tengo que puntualizar que hay estudios en otros países donde la gente sabe que no tiene una red de seguridad, sabe que si no se cuida y aparece la enfermedad, luego no hay marcha atrás y el sistema sanitario no les va a apoyar. En España nos encontramos con la dificultad de que las personas saben que tienen la red de seguridad de un sistema sanitario público de alta calidad. Y dice, yo sí quiero comer bien, voy a comer bien, me voy a poner doblado de sal y de colesterol, que luego ya vendrán y me darán una pastilla para la tensión o me darán una pastilla para el colesterol. Eso dificulta en ocasiones los programas educativos y convencer a esas personas para que se cuiden. Simplemente quería comentar eso. Bueno, pues sabemos que tenemos que promover los hábitos saludables, que las personas se cuiden y demás, ¿no? ¿Cómo podemos conseguir que las personas cambien sus conductas poco saludables? Bueno, pues una de las posibilidades es que los médicos y las enfermeras estemos encima. ¿Qué ocurre? Que se estima que de todo el año, más o menos, las personas tienen 10 horas con los profesionales sanitarios para toda la atención. Entonces, difícilmente vamos a poder realizar grandes cambios conductuales, grandes cambios en los estilos de vida con tan poco tiempo. Ese es uno de los mayores problemas que yo creo que tienen los profesionales sanitarios, el poco tiempo que pueden permanecer con sus pacientes, ¿vale? Entonces, ¿cómo podemos mejorar esto? ¿Cómo podemos conseguir que los profesionales sanitarios, en este caso yo voy a hablar de enfermería, podamos realizar grandes cambios en nuestros pacientes? Pues bueno, teniendo herramientas que nos ayuden a personalizar los programas, a personalizar el tratamiento que llevan los pacientes. Y podréis decir, personalizar los programas o personalizar los tratamientos, eso suena a más tiempo. Es decir, tenemos poco tiempo para estar con ellos, pero encima los tenemos que personalizar. Pues sí, porque ¿qué ocurre? Que muchas veces, como no tenemos tiempo, sacamos o prescribimos programas educativos, programas de salud genéricos, para todos por igual. Y todos los pacientes no necesitan todo, no necesitan un programa educativo de la misma forma, porque todos no tienen las mismas carencias. Hay gente que tiene unas carencias en algunos aspectos, pero tiene potencialidades, tiene grandes destrezas en otros aspectos. Entonces, ¿qué tenemos que conseguir? Diagnosticar, definir en qué aspectos del autocuidado algunos de nuestros pacientes tienen las mayores carencias. Pero ¿cómo podemos hacer esto de forma rápida? ¿Cómo podemos conseguir de forma rápida determinar cuáles son las carencias de nuestros pacientes? Pues con herramientas. Una de esas herramientas es SCODI, que es el Factor Diabetes Inventory, que es un cuestionario para determinar cómo es el autocuidado en las personas con diabetes. Esta herramienta en sí está formada por 4 subescalas. Esto es un cuestionario que está dividida en 4 subescalas, que son el mantenimiento, la supervisión, la gestión y la confianza. ¿Qué ocurre con este cuestionario? Si pasamos nosotros un cuestionario que se rellena de forma rápida, en torno a 5 o 10 minutos, lo rellena rápido el paciente y además lo hace sin necesidad del enfermero estar encima o demás, o sea, lo puede hacer incluso en casa. Y rellenando ese cuestionario, nosotros podemos identificar sus carencias, podremos dirigir nuestros programas hacia donde el paciente flojea, donde cojea en ese aspecto. Por ejemplo, el mantenimiento del autocuidado. Las preguntas que versan sobre el mantenimiento están muy relacionadas con cómo se comporta el paciente en cuanto a los hábitos y conductas de mantenimiento de su estilo de vida. Esto sería en plan, ¿qué tal come? Si come sin sal, si controla su peso, etcétera. En cuanto a la supervisión, esto se refiere más a la monitorización de, por ejemplo, su azúcar, su glucemia. Si se controla el azúcar diariamente, si se monitoriza el estado de sus pies habitualmente, etcétera. En cuanto a la gestión, se refiere a qué hace el paciente cuando detecta que tiene un problema. Es decir, tú puedes mirarte el azúcar todos los días y determinar que de repente tienes 300 de azúcar. Vale, pues ya está. Es decir, no te has dado cuenta que eso es un problema. Sabes realizar la técnica, pero no sabes qué tienes que hacer cuando eso ocurre. Pues en este sentido, esta pregunta lo que te identifica es si tienes los conocimientos y las habilidades para saber que cuando eso ocurre hay que hacer algo. Tienes que ponerte insulina rápida, tienes que variar tu dieta, tienes que acudir a un centro sanitario, sobre eso, ¿no? Y luego está el tema de la confianza. La confianza en estos cuestionarios tiene un apartado especial porque está contrastado que la confianza del propio paciente en cuanto a si él va a ser capaz de realizar los otros 3 elementos, si él tiene confianza, siempre va a ser mucho más positivo. Es decir, va a tener éxito el autocuidado. Entonces, ¿de qué nos serviría a nosotros pasar este cuestionario a esos pacientes y determinar eso? Bueno, pues por un lado nos sirve para medir en un momento determinado esos aspectos del paciente. Por otro lado, monitorizar, es decir, yo veo la situación basal, considero que tengo que programarle un programa de mejora en la técnica de la medición de glucemia y luego puedo volver a medir a ver si han mejorado. Es decir, veo un antes y un después. Y luego me ayuda a prevenir, a predecir, a actuar y a personalizar los programas educativos. Lo que os decía, pues va a haber un grupo de pacientes en el que vamos a tener que realizar un programa exclusivamente para ayudarles a tener destrezas en la toma de glucemia capilar, otro grupo de pacientes en los que tenemos que mejorar su confianza, ayudar en la confianza, y otros, igual lo que tenemos que hacer es enseñarles cómo tener hábitos de vida saludables, punto. Y entonces vamos a mejorar la eficiencia de nuestros recursos sanitarios. Vale, pues nosotros este cuestionario no lo he diseñado yo, de hecho, bueno, ahí quería poneros la foto de David, lo pongo porque también es otro enfermero que ha desarrollado otro cuestionario, es decir, teoría de enfermería, cuestionarios realizados por enfermería, grupos de investigación de enfermería. Bueno, pues lo que vamos a hacer en nuestro programa es la traducción y validación de este cuestionario. Cuando nosotros tenemos un cuestionario en otro idioma que es diferente al castellano, lo digo porque no lo sepa, lo tenemos que traducir, pero no se puede traducir con el Google y variar las palabras, porque eso solo es una traducción, pero tenemos que interpretarlo, es decir, por ejemplo, hay un ejemplo, pues judías asadas no son señoras de Israel, metidas al horno, o palabras por el estilo, ¿no? Que no se puede traducir simplemente, sino que hay que interpretar lo que quiere decir. Y luego tenemos que adaptarlo culturalmente. Por ejemplo, el Scodi iraní, el Scodi al lenguaje persa, elimina la monitorización, el chequeo del estado de sus pies, la higiene de sus pies, como pregunta clave. ¿Por qué? Porque en la cultura musulmana el lavado de pies es algo endémico de la cultura, es decir, siempre todo el mundo lo hace varias veces al día. Entonces no tiene sentido. Todo lo que no tiene valor en un cuestionario lo tenemos que eliminar porque estamos perdiendo el tiempo. Pues eso es lo que es una adaptación cultural. Y luego, después de todo esto, lo que tenemos que hacer es validarlo psicométricamente. Es decir, comprobar que lo que decimos que mide sirve realmente para medirlo. Y en eso estamos. Cuando nosotros desarrollamos el proyecto, lo que tenemos claro es que para validarlo, según la bibliografía y demás, necesitamos una muestra de 210 personas. Tenemos que pasarle el cuestionario a 210 personas para que nos dé los resultados esperados. Entonces decimos, ¿cómo vamos a conseguir que 210 personas con diabetes respondan a nuestro cuestionario? Pues en un principio yo pensaba que iba a ser muy fácil, la verdad. O sea, pensaba que me iba a costar poco. Digo, anda que no hay diabéticos, ¿no? Y tampoco va a costar tanto. Bueno, pues describimos, ahora os digo, describimos dos metodologías, dos formas de captar a los pacientes. Una de las formas era visitar la segunda, consideramos que era ir a ver a pacientes del Hospital San Pedro. Entonces, después de pedir los permisos pertinentes, nos dieron permiso para visitar a pacientes un día a la semana de la segunda planta del Hospital San Pedro. Son 4 controles y nos permitían una tarde ir a visitar a los pacientes. La otra vía de difusión era difundir el cuestionario entre personas con diabetes, diabéticos, y pensamos que la forma de hacerlo más correcta era a través de asociaciones de personas con diabetes. Es decir, buscamos asociaciones de personas de diabetes de toda España, hablamos con ellos y las difundimos. Entonces, realizamos nuestro estudio observacional transversal cuantitativo. La población era de 210 personas, que es lo que necesitábamos, y la duración del estudio nos lo marcaba el tiempo necesario para captar las 210 personas, los 210 cuestionarios. Entonces, en un principio no teníamos ni idea de lo que nos iba a costar. Decir que el Hospital San Pedro está formado por 630 camas, pero el permiso que teníamos era para visitar 89 habitaciones, que son los 4 controles de la segunda planta. Vale. El protocolo que decidimos tomar era los lunes, un técnico contactaba 4 horas con las asociaciones de diabéticos. Estábamos 4 horas llamando a diferentes asociaciones en orden, llamábamos a una asociación, le contábamos nuestro proyecto, le pedíamos ayuda y si le parecía correcto le enviábamos el cuestionario, que solamente desde la asociación lo único que tenía que hacer es difundirla, es decir, enviarla a través de WhatsApp o correo electrónico. Los martes por la mañana, un trabajador del hospital, yo, seleccionaba a los pacientes de la segunda planta viendo cuáles de ellos eran diabéticos. Yo veía de los pacientes de la segunda planta qué pacientes eran diabéticos. Y entonces lo pasaba al técnico de la universidad, que por la tarde los visitaba, los pacientes de la segunda planta que eran diabéticos. El jueves, el trabajador del hospital, yo, recogía los cuestionarios que nos habían dejado. Vale, el desarrollo. El estudio comenzó, la recogida de datos comenzó el 13 de enero de 2022 y finalizó el 30 de enero de 2023. Es decir, nos costó un año. Lo que pensaba yo que iba a ser muy rápido, pues fue un año. En total fueron 382 días, pero en realidad fueron 38 semanas de trabajo. ¿Por qué? Porque no todas las semanas se trabaja, hay enfermedades, hay compromisos y demás. Realmente trabajamos 38 semanas. Y recogimos los 210 cuestionarios que pensamos. Respecto a la entrevista personal, decir que en el periodo que estuvimos visitando a los pacientes, observamos una ocupación de la planta del 91%, es decir, una media de 81 pacientes a la semana. En total, seleccionamos 624 pacientes diagnosticados de diabetes mellitus en un año. Y de ellos, más o menos, la media era que fueron visitados 16,4 personas a la semana. Es decir, cada semana más o menos el técnico visitaba a 16 personas. Pues bueno, el resultado es que de todas las personas visitadas nos aceptaron y nos contestaron 90, el 14,42%. Y frente a ello, 534, es decir, el 85%, no quisieron colaborar. Hay que decir que todas las personas que eran visitadas en el hospital, evidentemente, estaban en un proceso de enfermedad aguda, de intervención quirúrgica y demás. Es decir, por un lado entendíamos que tenían tiempo, pero por otro lado entendíamos que no tenían ninguna gana, ¿vale? Hay que decir, en cuanto a esto, que a mí sí que me llamó la atención que la dirección sí que nos dio permiso para realizar el estudio en esta planta, pero yo trabajo en el bloque quirúrgico y el último año, si no hemos hecho por lo menos, no hemos realizado por lo menos 3 estudios de los anestesistas, no hemos hecho ninguno. Y en esos estudios yo como enfermero he tenido que realizar muchas tareas, desde recoger datos hasta realizar analíticas y demás. Respecto a un estudio de enfermería en el hospital, la autorización fue que podíamos realizarlo, pero que las enfermeras no podían perder ni un minuto en el estudio. Es decir, ni siquiera podían recoger los cuestionarios. Para que veamos, no por nada, sino en plan, la diferencia en las facilidades que muchas veces tenemos los enfermeros versus lo que tienen los médicos a la hora de realizar un estudio en el mismo centro, ¿vale? Respecto a la segunda forma de difusión, la difusión de cuestionarios, hay que decir que vimos que en España, en ese momento, había 123 asociaciones de personas con diabetes mellitus distribuidas en 50 provincias más las 2 ciudades autónomas. La distribución era heterogénea, es decir, había provincias con 8 asociaciones y provincias en las que solo había una asociación, como por ejemplo La Rioja o Navarra. Recibimos 120 cuestionarios, es decir, recibimos los 120 cuestionarios que nos faltaban, y las respuestas vinieron de 19 provincias, es decir, del 36,53% del total. Es decir, el 63% de las provincias no recibimos ningún cuestionario, solo lo recibimos de 19 provincias. No sabemos exactamente cuántas provincias colaboraban y cuántas no, porque algunas provincias tienen más de una asociación. Entonces no podemos saber en sí las asociaciones, sino solo sabemos las provincias. Hay que decir que recibir 120 cuestionarios de 123 asociaciones, pues la verdad es que llamaba un poco la atención. Tengo que decir que, bueno, aquí tenéis una imagen que muestra de las 210 cuestionarios, 120 corresponden a la difusión de cuestionarios, el 57,14%, y 90 a la entrevista personal, que es el 42,85%. Es decir, un 14,29% es superior la difusión versus la entrevista. Hay que decir que para nosotros era mucho más fácil, o sea, en cuanto a la metodología, era mucho más fácil la recogida de datos de la difusión de cuestionarios a través de las asociaciones, porque solo se lo teníamos que explicar a una persona de la asociación. Si le parecía bien, lo difundía; si le parecía mal, no lo difundía. Y por la forma de rellenar el cuestionario, directamente los datos que nos llegaban nos venían en formato electrónico y era muy fácil volcarlo, versus el formato en papel que teníamos que pasar por el hospital, aparte de que teníamos que seleccionarlos previamente, teníamos que pasar a recogerlos posteriormente, y había que todos los papeles estaban en formato físico porque los pacientes se apañaban mejor y teníamos que volcar toda esa información en la base de datos. Pero también hay que decir que normalmente los cuestionarios estaban más completos cuando se recogían en papel y estábamos encima de ellos. Entonces, que es el resumen de todo, si tuviera que decir, volver a empezar el diseño del estudio y decir cuál es la mejor estrategia para la captación de pacientes, os digo de verdad que bueno, para empezar tendría que hacer los dos, porque si no, no llegamos. ¿Sabes? Intentaría más todavía para poder acortar el tiempo de año. Y no sabría deciros cuál es mejor de los dos, porque son bastante parejos y cada una de las dos estrategias tiene cosas buenas y cosas malas, ¿vale? Y nada, solo quería contaros esto. Muchas gracias, y si tenéis alguna pregunta, me decís.
Gracias, Jesús. Pues con esto hemos terminado por la mañana. Os recuerdo que a las 4:30 continúa el Congreso en la Facultad de Ciencias de la Salud, con las comunicaciones orales y los pósters. Gracias.